We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar HMB, organized by Tnfog. So it's my privilege to introduce the coordinators of today's webinar, Dr. Gayatri N. Ma'am, and also Dr. Radhika Gauri Ma'am from Tirunelveli. I welcome both the coordinators and hand over the session to them.
Thank you very much, Sahiti, for all the technical work that you always do so perfectly. I welcome all the faculty and delegates for this Tnfog Marathon Cme. We called it the Marathon Cme because this is done very, in a very scheduled manner, and it's always done, never missed even a month. Every month, the second Friday, we have this. And not only that, the platform also gives a very good opportunity for Yuva speakers to showcase their talents. Every CME, we have a UA session where doctors who are less than 40 years are given the chance to perform. And we have a few very, very eminent teachers who have also been examiners to question them slightly, making the whole program more interesting. Every year, one of these UA speakers will be honored in the annual CME. And after that, we have an eminent speaker talking on an important topic which is relevant to that month or the chosen topic of that month. And then we have a panel where we have an elaborate discussion on the basis of the same topic. So this is about the Tnfog Marathon CME. On this occasion, let's first start the program with the Tamiltai Varthu. Thank you, Shield, for the prayer song. Though this is just a virtual meeting, we don't want to skip the important and the more pious things of the usual CMEs. Let's also do the lighting of the lamp virtually. Thank you. With this, we'll move to the program. I take privilege in introducing our president, Dr. S. Vidya Prabhakar. She is taking over as the president from this CME. Welcome, ma'am, and we are hoping to be inspired by you throughout your year of tenure. She is now the president of the Tnfog with special interest in high-risk pregnancy infertility. She is the clinical director, chief consultant in Conceived Couple Care Clinic, Salem, and a senior IVF consultant in Birla ARMC IVF Center in Salem. Over to you, ma'am. Madam will now introduce our chief guest and the guests of honor. Meera, madam.
Thank you very much. Yes, thank you very much, Dr. Gayatri. Can you hear me?
This is not just a thing. Sampath madam kept it a little secret only. We have Dr. Meera Agnihotri, the chief guest, sharing the stage with her distinguished daughters, Dr. Rachna Dubey and Dr. Kalpana Dikshit, madam. Madam has not joined, ma'am.
Madam has not joined?
Kalpana madam is not joined yet. I'll do that. Over to you, Dr. Vidya Prabhakar.
Okay, good evening, everyone. And thank you very much, Dr. Gayatri and Dr. Radhika Gauri. Also, both of you have been doing a phenomenal job. Both of you are absolutely full of energy, and I think you people are really carrying it forward very well. I must say, I must congratulate you both on your effort. And let me first say, this is my first meeting as the president of TNFOG, although I've attended many of the marathon CMEs earlier. It always leaves me with that taste that, okay, there is something to be learned in every CME. Okay, although there are multiple CMEs going on everywhere, but our TNFOG CMEs are always full of knowledge, and it is always very disciplined, which actually makes me wonder. I think the credit goes to the stalwarts, Dr. Anjalakshi madam, Dr. Revati Janakiraman madam, Dr. Ramani Devi madam, and of course, Dr. Sampath Kumari madam, who has just taken it upon herself to project TNFOG as one of the major societies all over India. I think everybody has started noticing it now that TNFOG is a force to reckon with. So I think a big thanks to all these stalwarts who've been there. Thank you very much, ma'am. Dr. Revati Janakiraman is very much around, I think. Thank you, ma'am, personally. I can't see who are all here, who all have logged in. So Dr. Meera Agnihotri has logged in?
Yes, she's there.
Okay, can I have her CV, please?
Hello.
Yeah, hello, ma'am. Welcome to the CME.
Okay, good evening, everybody.
I would just like to read out your CV first, ma'am.
Need not to. Vidya, it's okay.
No, ma'am.
Need not to. It's not desired.
Ma'am, it's not about pleasing you, ma'am.
It's our privilege, ma'am.
About how much you've achieved.
It's our privilege, actually. So I'm proud and happy to introduce Dr. Meera Agnihotri and welcome her as a chief guest for this CME. She's Professor Emeritus, Professor and Head Obstetrics and Gynec Department, GSVM Medical College, Kanpur. And she has achieved a lot of laurels, and she is an advisor, Women's Health Cell, Ministry of Health, Government of India. So you should understand, like, how tall she stands. So, President WWW Foundation.
Vidya, we have got a long academic session. So, thank you very much, darling. We will meet again and discuss it. So, at the outset, I extend my heartfelt gratitude to Vidya, especially when she is telling that she has joined very recently, and this is probably her opening session as a president of this society. I'm really grateful to all the organizers, including Dr. Sampath Kumari, who is a very good friend of mine, and I personally feel that I keep on meeting her here and there in many meetings. We are chairing the session, we are discussing the things, and sometimes we are in the panel discussion and so on. So Sampath, thank you very much. And you must never forget the treasurer, because he is holding the strings of the purse. So he has to be given very much importance. So Sarvan Kumar must be given importance. So Vidya, Sampath and Sarvan, I am very grateful for all of you for choosing me as your chief guest, which I am not. I am really a part of this society. I am, and I will always be a part of this society because Dr. I know Revati, I met her very many times. She loves me, she regards me, and so many faces which I am seeing, they are there with me since very, very long time when I have conducted the first AICUG at Kanpur. So this society is not new, and I have partly learned Tamil Nadu also, so that I can at least understand whatever you are telling, you are loving, and so on. It's very important to share the session with Dr. Kalpana Dikshit and Dr. Rachna Dubey from Bhopal. Rachna has become a national figure. She is
Director, Medical and Education, so she will be attending you very soon. I'm very much impressed that the subjects chosen for today's discussion are very, very nice. Yuva section, apart from that, the adolescent health is Dr. Sampath Kumari and your president, they are very, very important. Besides discussing them over these panels, where we are doing it right now, you make it a part of your program as health at your doorstep. What do we mean by that? Health at your doorstep. You select certain schools, colleges, where there are adolescent girls. And these adolescent girls must be told about menorrhagia, dysmenorrhea, what should they do as a menstrual hygiene. I mean, small little things which we are discussing here, it must go up to the last person of the country. So, Sampath is already having so many things in her mind before she takes over the charge. So, I personally feel that these things are very, very good, attractive, enchanting, and good to discuss, but they must reach up to the last person. And you must make it possible that health at your doorstep must be provided to our girls. So it is a very good session. I believe I wanted to, you see, be with you up to the end, but because of my prior appointments, I have told to these young, glittering girls, Radhika and the other one, very sweet, very charming, that I'll definitely be there, but I may not continue for long. I will be there for 10 minutes, 15 minutes. So I believe Vidya, Sampath Kumari and Sarvan will please pardon me for leaving this thing. I convey my regards to Dr. Revati. She is probably not here in the meeting. Is
She's
she
here,
there?
ma'am. She's
Dr.
here.
Revati is there.
Dr.
She's
Revati.
here.
Dr. Sampath Kumari madam is not there.
Achha, why? Where has she gone?
She's coming by flight, madam. She's flight got a bit delayed.
Okay. But convey my regards to all of them. I know everybody, Dr. Bhavakar and everybody, they are with us all through. So please convey my love, blessings and regards for this wonderful meeting. And once again, I extend my heartfelt gratitude to all of you for making me a part of this great meeting, which is very relevant in the present situation. Thank you very much.
Thank you very much, ma'am, for those kind words. And we are extremely happy to have you here, even if it is for a short while. And I'm very happy that you were there for my first meeting, and your blessings mean a lot to us. And that idea of health at your doorsteps is extremely good. Although we all conduct camps, I think we'll call it like this, and then we'll make it a little more popular, like you said. And I think we'll take it to the heart of the society. I think thank you very much for that suggestion.
Thank you.
Can we? So now I would like to welcome Dr. Kalpana Dikshit, Senior Obstetrician and Gynecologist, Director, Jimny Hospital. She is President, Kanpur Obs and Gynecological Society from 23 to 25. And she's organizing secretary of IMSCon 2025 to be held in Feb 21 on Feb 21 Kanpur. Organizing Secretary, WW NatCon 2024 to be held in September 21. Oh my God, she is a real busy bee. She's been organizing a lot of conferences and is going to be organizing as well. We are very proud to have you here. Welcome, Dr. Kalpana Dikshit.
Madam is not joined, I think.
Madam is not yet joined yet.
Yeah.
The next TV? Dr. Rachna?
Yeah, I'm there.
Rachna madam is here.
Yeah, so I would like to welcome Dr. Rachna Dubey, very charming and I think well-accomplished guest for today. And she's Director, Health in Charge, Government Kailashnath Kajju, Exclusive Women's Hospital, Bhopal. And she has won a lot of awards and recognitions. National Award, Outstanding Initiative Promoting Women's Healthcare Services, and ISA Distinguished Service, and attended course at Harvard Medical School, USA, my. And she also has won the Doctor's Day Award 2020. And she has got a lot of these awards and accolades. And we are very proud to have you indeed. And welcome you, Dr. Rachna Dubey.
Thank you. Thank you so much for inviting me to this landmark Tnfog Marathon Cme. It's such an important subject that I couldn't say no. And especially when Madam Sampath Kumari Madam called me, I was overexcited to be a part of whatever she is doing, because she is one of the most excellent academician. And I can see some very learned people in the faculty. I would like to take a moment to acknowledge the presence of my mother, Dr. Meera Agnihotri, over here. She's not only a senior gynecologist, but actually a revered field in this field, whose gratitude has shaped my clinical journey. I also thank Dr. Sampath Kumari Madam, Dr. Revati, Dr. Vidya, and Dr. Radhika, who are present over here. I know the CME not only reflects the academic rigor of this community, but also its deep commitment to addressing conditions like that significantly impact the countless women across every age group, every socioeconomic background, in every region. Because being director health and at the same time looking after the exclusive women hospital of Madhya Pradesh, I feel that such an important topic should be communicated to masses, because heavy menstrual bleeding is an often underreported, misunderstood, and frequently normalized condition. It is not just a gynecological concern, but I personally feel it's a big public health issue affecting the quality of life, and in many cases a gateway to diagnosing a lot of broader systemic and hormonal conditions. So today's CME is really important. And I can also feel that these CMEs, especially on heavy menstrual bleeding, the old assumptions which you have, it's going to spark to new thinking and empower everybody to recognize, diagnose, and manage heavy menstrual bleeding with precision and empathy. So thank you very much for calling me here and being a part of this workshop. Thank you so much.
Thank you so much.
Thank
Dr.
you.
Rachna Dubey, actually, those are words coming from your heart, because you've been working in an exclusive women's hospital and you know how important it is to deal with HMB. Yeah, so thank you very much for those words.
Thank you so much. Thank you so much.
Yeah. Dr. Gayatri and Dr. Radhika.
I think Kalpana Madam is not yet joined, ma'am. So shall we go on to the CME? I'll call her up again when she's coming.
Yeah.
Over to you, Radhika.
Good evening. I'm very thankful to the Tnfog President, Dr. Vidya ma'am, and Sampath ma'am, and Anjalakshi ma'am, and all the senior consultants for giving me this opportunity. And I thank Meera ma'am for the wonderful advice and all the advice regarding the health at doorstep. And we will invite Dr. Shanti ma'am to take up the next program. I mean, she's a professor of Department of Obs and Gynae, Savita Medical College and Hospital, Chennai, Tamil Nadu. And she's a student of MBBS, Madras Medical College, both her undergraduation and post-graduation in Madras Medical College. And she's trained in ultrasound in Obs and Gynae, advanced infertility, advanced laparoscopy. She's also provider and instructor course, and she's got almost 25 plus publications. Field of interest is endoscopy, high-risk pregnancies, and adolescent gynecology. And she has won the gold medal in UG and PG, and also she's an examiner and invited faculty in various conferences. The other examiner today is Kartika Prabhu. She's a professor from SRM Medical College Hospital. I think her baby
joined, ma'am. Today she's not coming.
She's her birthday. I think her daughter's birthday today, so she's not joining today.
On behalf of Tnfog, we wish her daughter a very happy birthday.
Yes.
Happy birthday. Very happy birthday to her. Please do convey.
Sure, ma'am. We will tell Dr. So, Madam Shanti, ma'am, would you like to introduce Dr. Divya?
Yeah. So, good evening, one and all. So, I thank the organizers of the Tnfog, especially Dr. Sampath Madam, for giving me the opportunity to be a part of this monthly webinar. So, today's webinar, your speakers are, the first speaker is Dr. Divya. She has done her MBBS and MS and MCE in Australia and FRM. She is a consultant fertility specialist and obstetrician gynec at Mount Kaveri, Trichy, and a matter of clinical embryology. And she has done her fellowship in reproductive medicine under Dr. Kamini Rao, Bangalore. And she has done her fellowship in fetal medicine at Mediscan. She has done her diploma in minimal access surgery at Kiel University, Germany, and has underwent training in hysteroscopy as well under Dr. Osama Shirki. And she has also underwent laparoscopy training under Dr. P.G. Paul Virgin. Her areas of interest are infertility, infertility-related endoscopy, and fetal medicine and obstetrics. So over to you, Dr. Divya. So we are looking forward to hear to you.
Thank you, ma'am, for the kind introduction. I would like to thank Sampath Kumari, ma'am, and the organizing team for giving me this opportunity. The topic given to me today is puberty and delayed puberty. When I look into puberty, it's actually a fascinating field and various switch on and switch off neuroendocrine transmitters happening in our girls' life, starting from the fetal stage onwards. If you see an interesting fact that when I look into it, apart from humans, even apes, this elephants too, and fruit bats also menstruate. So puberty is something which links a girl's pubertal life from childhood to adulthood. There are various hormonal and secondary sexual characters development throughout the pubertal period. The most important physical changes happening is the breast development and followed by the pubic and axillary hair growth up to the adult uh, uh, period. And there is also increase in height of the girl and followed by menarche. So if you see, although there is breast development and adrenarche which starts early, it is overtaken by the growth spurt. So which comes first? First, the girl will have a growth spurt, followed by thelarche, then adrenarche, where normal pubic and axillary hair grows, and it finally matures into adult form at around 15 years of age. And also she attains a peak growth height, followed by menarche. So all these changes are usually completed between the age of 10 years and 16 years of age. There is something called as ontogeny of the hypothalamo-pituitary and gonadal axis, that is starting of an organism from the embryology stage to the adulthood. So there is something called as a hypothalamic pulse generator, which generates the GnRH release secretion. There are around 1,500 to 2,000 neurosecretory cells which secretes the GnRH in a pulsatile manner, which is present in the hypothalamus arcuate nucleus. So it is actually autorhythmically happening. This hypothalamo-gonadal axis becomes functional even before birth. If you see the fetal life to infancy, these neurons originate in the olfactory placard, where it migrates from the olfactory placard to the hypothalamus, which happens around 9 weeks of gestation. And the pituitary develops portal venous system around 10 weeks. And they start secreting FSH and LH at 12 weeks of gestation. So there is peak FSH and LH secretion at around 20 to 24 weeks, where a lot of primordial follicles develop.
Excuse me, you need to keep up your time. It's 10 minutes, right? Okay.
Okay, ma'am. Okay.
Yeah. Thank you.
Thank you, ma'am.
Ma'am, it's 12 minutes for the talk and 3 minutes for discussion, ma'am.
Okay. After in childhood and early adolescence, there is a juvenile pause. So although the GnRH pulse generator is active and there is some secretion of GnRH secretion, but there is no increase in the steroid hormone concentration. So that's why there is no secondary sexual characters which is happening in the childhood until the pre-pubertal stage. So 1 year before breastfeeding, there is increase in the secretion of LH, which increases the secretion of estrogen, and GnRH receptor also increases, which causes the neuroendocrinal switch from inhibitory stage to excitatory neuronal stage, mainly regulated by the kisspeptins, which controls the level of GnRH neuronal activity from the infancy to puberty. So this kisspeptin G protein coupled 54 signaling is the main mechanism that triggers the onset of puberty, which is now even used as a trigger in IVF cycles to prevent OHSS. So in endocrinology, if you take the gonadal steroids and gonadotropins, they are low until the age of 6 to 8 years because of low negative feedback from the estrogen and hypersensitivity to this low estrogen levels. But it gradually gets lost once a girl reaches the puberty. So the timing of puberty is also influenced by the genetics, and also it is already pre-programmed in the chromosome 6 and 9. So once the estrogen is increased, there is increase in the growth hormone and insulin-like growth factor, which causes the growth spurt, then causes the philarchy, which completes by 15 years of age. So the breast budding starts around 9 to 10 years and then gets completed around 15 years. This estrogen regulates the secretion and the formation of the gonadal organs like uterus, vagina, vulva, and also the breast. If you see at birth, the uterus size, the corpus uterus is smaller than that of the cervix, but when it reaches the adulthood, the corpus is more than the size of the corpus is more than that of the cervix. Then the adrenarche starts around 7 years of age, where the main hormone is the DHEAS, which starts the secretion of androgens, and then development of the pubic and the axillary hair happens. So once all these are happening, the first onset of menstruation in life is called as menarche. It is mostly anovulatory, and to take a proper ovulatory cycle, it takes around 2 years of period after the puberty. So if you take from breast bud to the adult pubic hair, from it starts around 10 years and it gets complete around 14 to 15 years of age. So these are all the regular sequence and the normal sequence happening in puberty. So when we call it as delayed puberty is when we don't see the proper breast development by the age of 12, that is around 13 or 14 years if they're not having adequate breast development, or if they're not menstruated up to 16 years of age, then we call them as delayed puberty. It is mostly because of hypogonadotrophic hypogonadism. Mainly, there are various causes like functional GnRH deficiency or constitutional delay or any chronic illness like malnutrition, exercise, or genetic causes. Apart from this, we have also other causes like pituitary tumors, chemotherapy, gonadal radiation. And you have to do a proper evaluation of these girls who come with delayed puberty, take a detailed history, rule out chronic illness, and take a family history and examine them properly to name it as delayed puberty. And also you should look into underlying causes like inflammatory bowel disease or hypothyroidism. If they come with symptoms of headache, visual disturbance, then we should also do a MRI brain to rule out CNS causes, and also do a karyotyping to rule out genetic causes. So we have to examine the girl in detail, like starting from height, weight, arm span, and do a proper Tanner staging of the breast and the pubic hair. And bone age evaluation is very, very important. We call them as the unicoid body habitus, where the arm span is more than that of the height of the patient, where there is delay in the closure of epiphysis because of hypogonadism. If you see a patient with Tanner stage 2, then you can assure the family that she might get a spontaneous puberty. And if you come across a patient with midline defects like cleft palate or cleft lip, you should think of GnRH deficiency. When you exhibit a bone age, if it is 12 to 13.5 years, it does not progress further in case of delayed puberty. You should also, once after doing an examination, do an investigation and do hormone analysis like FSH, LH, and estradiol, see whether hypergonadotrophism or hypogonadotrophism. If the FSH is undetectable, probably it is due to GnRH deficiency. Or if the FSH is low and estradiol is also low, it is mainly because of pituitary suppression and dysfunction. Apart from that, we should also do prolactin and TSH and pre-T4 evaluation. And DHEAS is mostly will be normal in case of GnRH deficiency. Apart from this, we have to also do CBC, ESR, and LFT to rule out chronic illness, and USG pelvis to rule out Mullerian abnormalities, which is the most common cause of primary amenorrhea. Then do a MRI brain to rule out pituitary causes. Here is the olfactory bulb and the tract. If you see, if it is absent in the case of Kallman syndrome, and you can also rule out a pituitary tumors by doing MRI brain. So when you come across a patient with delayed puberty, do a bone age assessment, do hormone analysis, whether hyper or hypogonadotrophism. If hypergonadotrophism, do a karyotyping and rule out Turner syndrome or any other chromosomal abnormalities. Or do a brain MRI, CBC, ESR, and LFT for other causes of delayed puberty. So how to treat the delayed puberty is we have to start around on hormonal therapy mostly after 12 years of age, because we should not allow for premature epiphyseal closure. A short-term goal is age-appropriate secondary sexual development, growth spurt, bone density, avoid premature epiphyseal closure, and monitor the age once in 6 months following the therapy. So you have to give them estrogen therapy for at least 2 to 3 years, either transdermal or oral, starting with low dose. You can gradually increase the dose around about 3 to 6 months once. Once the patient has a complete adult breast development, you can start around progesterone for bleeding. So it is very, very important. You should start the progesterone only later after 12 or 14 months of estrogen treatment, once the menses or the once menses begins. Otherwise, the patient will not have a proper breast development. So persistent hypogonadism beyond 18 years clearly suggests that she might have some congenital GnRH deficiency. If you come across a patient with isolated GnRH deficiency, our main long-term goal is maintain the hormone levels and normal physiological levels to induce ovulation with exogenous gonadotropin therapy, and the fertility is a first priority. You should never advise for a growth hormone therapy directly before documenting GnRH deficiency. But when we start with the estrogen therapy, automatically it increases growth hormone and insulin-like growth factor and causes growth spurt. So growth hormone is usually normal in GnRH deficiency. So to summarize, the onset of puberty is an evolving sequence of steps. The hypothalamic, pituitary, and gonadal axis, they develop during the fetal life, and it attains its full functionality before birth. In late infancy and childhood, there is inactivation of the central inhibitory mechanism or high sensitivity for the estrogen, which causes inactive state. Later on, it gets activated in response to signals from periphery, and the axis gets reactivated and causes gonadotropin, increase in FSH and LH, and causes estrogen secretion, followed by breast development and uterus and vulva development. So there is increased rapid skeletal growth, which precedes thelarchy and puberty when sex steroids are increasing. And mid-puberty estrogen level increases and lead to proliferation of the endometrium and lead to menarche. This is mostly anovulatory. So any delay in all the above events causes delayed puberty. Most common causes constitutional delay or hypogonadotrophic hypogonadism. We have to investigate these patients to identify whether hyper or hypogonadotrophic hypogonadism. Start them on estrogen after 12 years of age and continue till the adequate breast development and put them on progesterone. Any hypogonadotrophic hypogonadism, do a karyotyping before treating these patients. Thank you.
Yeah. Thank you, Dr. Divya. It was a wonderful presentation. You just went through the physiology of the puberty and as well as the delayed puberty. And I just a few patients. So what would be the most common cause of delayed puberty?
Mostly it is constitutional delay, ma'am. So we have to compare and ask detailed family history. If they have a family history of constitutional delay, then we can wait. If the patient is having like stage 2 or something like that, we can wait for a menstruation.
Okay. So how would you assess the bone age?
We can do X-ray of the hand and then analyze the bone age according to the epiphyseal closure.
Yeah, that's right. And generally we say about whenever there is an uterus, right? We shouldn't start estrogen alone. Like we should be starting progesterone along with that. Like how do you say? What do you say about that?
Because estrogen can cause endometrial hyperplasia when we started alone. But in case of delayed puberty, we are going to start only low dose and monitor the patient for endometrial thickness. So initial.
Do we monitor for that? Is there any protocol like monitoring them for endometrial thickness?
We should also, along with that, monitor for secondary sexual characters.
So actually speaking, like estrogen can be started alone. Like it is like a natural puberty. So even in natural puberty, it's the estrogen first that comes and then only progesterone. The same way, so we can give until the age of say normal puberty, say up to 16 or so. Okay, we can start estrogen alone. Okay, and later on add the progesterone, as you mentioned. Early addition of progesterone earlier can inhibit, may not
breast development.
Yeah, so expected development. Anyway, it was a good presentation, Dr. Divya.
Thank
All
you.
the best.
Thank you.
Thank you.
So I request Shanti ma'am to invite the next presenter, Dr. Dharani.
Yeah.
Priya.
So next is talk upon the menstrual hygiene by Dr. G.R. Tarani. She is a consultant at Tarani Hospital, Chennai. So she is joint secretary of Erode OGC, and she has done her MBBS at RMMCH, Annamalai University, and DGO at PSG, IMSR, and Dr. MGR University. And she is a former senior resident at Erode Government Medical College, Perudurai, and she is organizing committee member, Erode OGCon in 2023. And she was also the faculty at South Zone UA FOGSI 2023, Tnfog 2024, and her field of interest are high-risk obstetrics. So over to you, Dr. Dharani. So your time starts now.
Dharani ma'am, just say next. I will share it. Dr. Dharani ma'am.
Can you hear me?
Yes, you just say next.
Okay, ma'am. So my topic today is about the menstrual hygiene, the most important issue and the least discussed in our field nowadays. So the next slide. The next slide, ma'am. Next slide. So why the menstrual hygiene? Because the menstrual hygiene not only depends on the girl's hygienity, it also depends about the education, economy, and health and environment. And the human rights also depends upon this, ma'am. So next slide. So my topic is today about how to practice a good menstrual hygiene and the changes menstrual protects which regularly, and how to keep the genital area clean and why we should keep it clean. Next slide. So what is menstruation? It is an absolutely normal thing where the menstrual fluid is a harmless mixture of blood and tissue, and the menstruation is a good indicator for a health in the woman's health. But in India, we have lots and lots of menstrual myths, which is a menstrual woman is impure or sick. The menstruating woman, she cannot offer a prayer or enter into a place of worship, and she should not prepare food. Everything is going on still now. So why menstrual hygiene? Because there is a lack of sanitary material, including underwear in the northern states, and there is a lack of private female-friendly toilets and bathing spaces, lack of knowledge on menstruation, and anxiety and embarrassment around the leakage and the discomfort. And there are lots and lots of cultural taboos and restrictions still going on in the rural areas, and there is overcrowding and severely diminished privacy for the women. The menstrual pain, where the 50% of girls, child who undergo symptoms like headache, heat, vomiting, pain, everything, and most of this depends on the treatment like pain relievers, healthy food, massage, warm bath, and heating pads. So moving on to the main topic, how to deal with the menstrual flow. Still, there are lots and lots of people who are depending on the sanitary pads, which should be changed every few hours, and the tamponades, which have been introduced last few years back, which should be changed every 4 to 8 hours, and the menstrual cup, which is changed every 12 hours and should be sterilized after each and every menses.
Hello?
And there is also periods underwear and also menstrual discs. So why we all can happen? What can happen if an hygiene is not maintained during our periods? The most of the genital area is moist, where there is a possibility of the infections to go around because of the dampness. So it is advisable to change the menstrual napkins or the tamponades. So according to the time. And this infection can causes of itching and irritation, which most of the OPDs we are seeing nowadays, girls coming with itching and irritation. So due to the dampness, the rashes is also along the line of the innerwear area and also is more common. So in India, the most appropriate, the common problem which are facing is India sanitary pad problem, where after each decade, we are seeing about 18,000 tons of napkins, which is being disposed by the girls and women used. So it is nowadays advisable not to use napkins. Instead, we can proceed with a menstrual cup or tamponades is advisable, ma'am, because these are decomposed material which goes under the soil, and they still they land for longs of years. So why the consequences? What are the consequences we are facing in the menstrual waste disposable are materials which clog the sweeper pipelines and disturb the soil microflora, and water bodies also get contaminated, and materials soaked with blood, and which are the breeding places for the germs and pathogenic microbes, and the sanitary products soaked with blood, which are may contains hepatitis and HIV virus, which retain the infection in the soil and lives in the months and in the soil. So what are the strategies for the management of the menstrual waste? This is how the menstrual napkin should be disposed, and this should be taught for all the girls who are in the school time. In Kerala, there are also some sanitary napkin vending machines which are not available in Tamil Nadu and in northern states. And there should be a separate collection system for menstrual waste, which should be given privacy and dignity of the woman. And the dustbin should be completely covered by the lid, so that it should be free from the flies, mosquitoes, and the bad odor. And there should be a water availability, toilet paper, and dustbins in the schools and the public areas. And there should be a proper safety tools for the cleaners to dispose the waste properly. So once we are using the sanitary napkins, there is also a lot of expense in this, and we are disposing about 12,000 kilograms of wastage in the menstrual napkins. So in case of tamponades, which is also the same, but the cost is little less, and there should be a leakage is prevented. And in case of menstrual cups, the cost is also saved and the waste is also saved. So what are the hygiene practices which should be practiced during the menstrual hygiene? Is to wear a lightweight, breathable clothing, change your menstrual products regularly, and to keep your genital areas clean. Use of unscented toilet papers or tamponades, and drink enough liquids, and to track and monitor the periods. So it is a main important slide, which is about what to eat during the menses to avoid unhealthy foods and snacks, and to include lots and lots of vegetables, eggs, and make sure that the kids are hydrated properly. So what are the taking action we should be follow to improve the condition of the menstrual hygiene management in school is to promote and to foster and reduce the stigma of the equal opportunity for the menstrual education. So we need to aware the kids about the menstrual hygiene, and poor menstrual health and hygiene is a crisis which involves not only the physical health and also the mental health of the kids. And this is a slide which should be displayed in all the OPDs, which shows the what are the available options for the menstrual and why we should use, and how the menstrual hygiene should be maintained with a proper hand wash each time after we changing the pads, and to carry the proper extra pads during the menstruation days, and to have a healthy clean bath, and to change the napkins each and every time after 5 to 6 hours to avoid stain, and also to prevent the infection. And do not use the soap or perfumes during the menses, and just to use the plain water is better. May 28 is celebrated as the World's Menstrual Hygiene Day, and it is better to follow in our OPDs and to aware the kids and women about the menstrual hygiene which should be followed. Thank you, ma'am.
Yeah, very nicely presented, Dr. Harini. So we are to add on, like, sorry. So we need to teach them that dysmenorrhea as such need not be physiological, because we all know like endometriosis is related to dysmenorrhea, which is usually presented as dysmenorrhea. So many of them like postpone their presentation to the consultant because it's considered as a normalcy. So that also should be included in the teaching, right? And anything about the dioxin and endometriosis?
Endometriosis is not common during, we should, as you said, it should be awareness should be given to the girl childs, ma'am. And
about dioxins, because a lot of papers, relating the type of menstrual pads they use and then relation to the endometriosis. That is one of the controversial topics still going on. Okay, dioxin and which is used for a bleaching of the pads, right? So, so that is also there. Okay. So like if they don't, we also need to tell them, like if they don't, if whenever nowadays we see students or girls using tampons and menstrual cups. So what we also need to tell them, right? What will happen if they don't, if you use it for a longer time or forgotten tampons? What is that?
they may go for toxemia also, ma'am, in case of tamponades. It is the main contraindication when the girls use tamponades.
Yeah, so that is also there. So we need to tell them the pros and cons of using all these menstrual cups. So these menstrual cups, again, initially it was like very much promoted, but now again there are papers to say that not to use in a very young age. Anyway, it is a cup, right? It's elastic cup. We don't know what would be the effect of this upon the mucosal membrane. Okay, so that is also there. Okay, fine. Anyway, it was a good presentation. Thank you.
Thank you.
That was a very good presentation by you, both the Yuvas, and both of them have been really time conscious too, finishing their talks just in time. This brings us to the end of the Yuva session. Thank you, Shanti Madam. Thank you, Shanti Madam.
Thank you.
Thank you, ma'am, for joining us again. With this, we go to the next session, for which I call upon Dr. Professor Revati Janakiraman to chair the session. She is the former director, IOG Chennai. She has been the past president of TNFOG, founder, secretary, and past president of Madurai OG Society. She's been the vice president of Foxy South Zone 2016. And she's a founder president of Madurai Menopausal Society, also a zonal coordinator for the HPV vaccine drive. She's got a lot of awards to her credit. A few of them include the Durusha Community Service Award, Lifetime Achievement Award from the IMA, and the Pride of Foxy Award in November 2019 at Mumbai. She has authored a lot of chapters, and she's also authored a lot of Foxy Focus. So over to you, ma'am, for the session. Revati Madam.
Revati Madam there?
Radhika Madam, you can introduce. I think she'll join.
Okay. Dr. Chitra ma'am is the founder director of Janani Trichy Fertility Center and founder director of Lalita Nursing Home. She's also director of Shamla Nursing Home, and she's underwent IVF training in Singapore under Dr. P.C. Wong, and IVF training under Dr. B.N. Chakravarti. Completed her undergraduation from Tanjore Medical College, post-graduation from Manipal University, and won the Best Outgoing Student Award. She's a passionate doctor on infertility and started the first IVF center in Trichy in 2004 and successfully completed 19 years of service with more than 1,000 IVF cycles. And she's the invited speaker and faculty in national conferences, and she's the secretary for Indian Fertility Society, South Tamil Nadu chapter, and also an organizing secretary of International Conference EndoMedCon. And she's a past president of TRIOGS, and she's a patron of our TNFOG, organized many public awareness programs in schools and colleges. We welcome Dr. Chitra ma'am.
Thank you, Radhika, for that.
Thank you, ma'am. And Chitra ma'am, daughter-in-law is our other moderator, Dr. Gayatri.
Dr. Gayatri.
Yeah, another mom and daughter pair, like Yes, ma'am.
Okay.
Thank you, Dr. Radhika.
I'll share my slides.
Yes, ma'am. Thank you.
Thank you very much for the opportunity given. Anyway, because this is one of the important things that all of us should know, being private practitioners, this is one accreditation program that can be offered by the FOXY. So Dr. Sampath Kumari wanted me to talk about this. Why it's not? Can you see my slides?
Yes, ma'am.
Yes.
Ma'am, but it's not in slideshow.
I
Just
know.
change it to slideshow.
Yeah, change it to slideshow. Yes.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay. So this Manyata is one important thing that all of us should know, because this has been offered by the FOXY to all the private practitioners to set a standard of practice. So this is mainly to improve the quality of our work, and it improves and gives training so that we have a quality improvement in our professional service that we provide our patients. It gives us a good certification. It can be put on your hospital anywhere outside, so that they know that you are recognized by FOXY as one of the trained centers to conduct deliveries and take care of the newborn. And this is mainly intended to standardize the care provided all over India for the antenatal, intranatal and postnatal mothers, and to take care of the newborn. So this standardization is in par with WHO and the National Standard of Care. That is, this Lakshya is a training program or the standard program that has been implemented into all the common sectors. So Manyata is equivalent of Lakshya, which is imparted to all the private practitioners, and it can be utilized by all the private nursing homes. Revati madam is here. Madam, good evening. I missed you for
Good evening. During PNFOG period, we did more than 100 centers certified.
That's what I'm one of those centers. So
Yeah,
probably that's why Sampath Kumari wanted me to talk about this.
Yeah,
Thank you, madam. Thank you for being here. So why do we really need this? Do we really need to be certified as a good center or things like that? Yes, it's very relevant, because it's our commitment to bring down maternal mortality rate. We all know about the SDG score and goal, and then we are almost trying to reach closer to it by 2030, which should be less than 70, and we are already nearly 40. So we should work hard to be even better than this, and we should have an uniform standard of care across the country, so the patient does not find it difficult if she has to go from one place to another. And it's mainly to strengthen the primary health care, especially in the rural India, where we have a major population still not knowing about the facilities available in the hospitals. And so they should reach a hospital, and we should give them the best care. And this entire unit or the entire program of Manyata will be focusing on quality healthcare that a doctor can give to her pregnant mothers. So this is an initiative which was supported by the MSD for the mothers. It has a connection with JPIGO, which takes care of all the antenatal, intranatal and postnatal mother care, and it is associated with the MacArthur Foundation as well. So it has a good support from all over the world. So it's a flagship initiative of FOXY. So initially, Dr. Hema Divakar took so much of initiation in starting off this, and she set the ball rolling. And after this has been incorporated into FOXY. And FOXY now has a separate unit which is helping us to get this certification. So it is mainly intended to improve the care of the that a private maternity care centers can provide. It promotes and adapts for us to adapt to the practice of 16 clinical and 10 facility standards, which has been documented, and they will help us and train us for this, and it will ensure consistent, safe, respectful care for the mothers during and after childbirth. So what are the benefits by having a Manyata certification? It empowers the doctors, nurses to follow evidence-based standard care of practice. It will be helping us to be prepared to handle complications and emergencies, and we should be vigilant. So they will teach us how to look for all these things. And the sisters are trained. They come online and they teach us how to when to do what, and improve the eligibility to attain the accreditation by any unit. they will improve. If we are bad, then they will tell us how to improve our standards. It will protect us from medico-legal circumstances, and it will give you a better recognition. So the insurance care providers will accept your center as a good unit, and they will give you recognition by their insurance companies. So it helps you to give an excellent service quality, and you will have ultimately a contented mothers and a happy doctor at the end of all your deliveries. So what will be the cost of the certification? For a 20,000 rupees, you will have to pay to get this accreditation if you have a facility which has only about 20 beds, and 30,000 rupees if the facility has more than 20 beds. So how can you register and get trained and certified? See, there is something called as Manyata for mothers.org. You have to click that, and then you have to go and click the certification icon. Then you get the Foxy National Program Management Unit. So they will take you through the next steps. And so it's very easy. The next steps would be enrollment, then training, then finally the certification will come to you. And all this can be done online. And only when they want to come and inspect your center, they may come in person. Now, how long will this training process take? It can take about 3 to 6 months. The centers for skill enhancement is also available. So in case that we want to go and learn, or everywhere in every district or every state now, they are trying to incorporate 2-3 centers who can teach the rest of the centers which are just getting introduced into this Manyata program. And there is a centralized training program which conducts all these trainings online. That is called as the ECO platform. So this certification would be valid for about 2 years, and repeated refresher courses will be available on ECO platform. And so you can improve every time you want to, every 2 years when you want to renew your certificate, you can have a refresher session and then do the best. So you can yourself do your periodic self-assessment and report it to the center. So if at all they require any changes in what you're doing, they will help you out on this. And random checks of the facilities are done to ensure and make sure that you adhere to the standards. So there is something now newly introduced. Safe Delivery app is also available on the Manyata. This is an innovative clinical tool that will help the birth attendant. It will help to access the evidence-based clinical guidance. So suppose the doctor is not available, only a VHN or a sister is available in the remote area. So she can use the app, she can learn the evidence-based clinical guidelines and take the help of the nearby doctor and then do what she wants to. Basic emergency obstetric neonatal care has been taught to all of them. And this can be downloaded from the Google Play and stored. But only thing is, right now it's available only in English and Hindi. So slowly they are planning to get it in all the regional languages as well. So this is the ECO program, or the Extension for Community or Healthcare Outcome, is a telemonitoring program. Again, this will connect both the healthcare providers and the specialists. So it is like all can learn and all can teach each other to improve the standards of what care you provide for your mothers who are pregnant and delivering with you. So what are other standards that this Manyata would teach us? There are about 16 clinical standards. First is the antenatal care. That will tell you that what are the things that you should do during the antenatal visits. Most of us are doing all these things, but still, because there is an SOP that you have to follow. Probably if you follow all these things, we will not miss out on picking up any complications. Like you have to establish the blood group and type in the first visit itself. Screen for anemia. HB estimation should be done every month. Then you should screen for HDP. Every month BP checkup should be done. You should check up for proteinuria whenever it is needed. Then do a screening for GDM. You can do a single step 75 grams because patients are coming from far away place. Then you can ask them to come need not ask them to come empty stomach early in the morning. You can do this OGTT anytime that they reach you. You can do it in the first visit, then you can do at 24 weeks and again at 32 weeks so that you don't miss picking up GDM at different stages of pregnancy. Screen for HIV and syphilis so that you know what will be the status of infection for the mother. Screen asymptomatic bacteriuria, which is not run routinely by everybody, but this gives us a lot of edge to prevent preterm labors. So this has also been incorporated into the standard of practice. So if we follow this SOP, we'll be probably even a little better off. The screening for malaria is only advised in endemic areas, not for everyone. So at admission, we have to follow these rules, like ensure sterile delivery tray is always available in your labor room. You make sure that the uterotonic drugs are available. Oxytocin, if there is, where you can give injections. And if not, also we should have misoprostol in our hand always. And both should be always available in all labor rooms. You keep a PPH kit. They give you the list of all the drugs or all the things that you should keep in a PPH kit. So once you go through the training, they will teach you what will be in the PPH kit and when what should be administered, like which is the first drug to be given, which is the next, which is the third, and when what you should do. All these things are taught to all the sisters. So even in case that you may take some time to reach that place, sisters will be capable of doing all these things. Only thing we have to teach them is to keep this kit always ready in the labor room with everything. One list should be done and pasted on top of the box, and they should check every month on the drugs that are available and make sure that the expiry dates are all there and it's never near the expiry date. And once you use, you should make sure that it is replaced. Same goes with eclampsia kit. So we should make sure that always Max Self is available. At least 20 ampules of Max Self should be available in these kits always. So this should be taught to the sisters. And this, the repeated drills that they do from the Manyata helps these girls to really do everything without any hassles. So that is what I have personally felt. Okay. There should be a resuscitation corner in the labor room where you can take care of the newborn and, teach them that the radiant warmer should be switched on 30 minutes before delivery. And all the resuscitation equipment should be kept ready before any delivery. It should be taught that for every delivery, it should be done. They should not run when there is a necessity. So when you are ready, most of the time you don't require. That's how it should work. So at the time, assessment of pregnancy at admission. So you take all the medical history, surgical history, obstetric history, everything should be documented. You assess the gestational age, you record the fetal heart, record the mother's BP, temperature. All these SOPs should be done and you should have one case sheet sort of a thing where all these things can be recorded properly. All these things are maintained by Manyata. So appropriate PV examination should be done, and you should make sure that the labor room has soap, running water, antiseptic solution, sterile gauze pads. All these things are ready always. Hand hygiene protocol should be taught to all of them. You can actually paste one in your labor room where you go for hand washing, so that, whenever they see that, they will again recall how they should do the hand washing. Then you should teach them to clean the perineum before the pelvic examination. Then alert the doctor if you see meconium in the LICA that's draining. And then how to record the PV findings should be taught. And it's taught for the doctors as well as the sisters, because Manyata allows sisters to do a pelvic examination. So not necessarily always doctors should be there to receive the patient and do a pelvic examination, because this is an obstetric unit. So they should be aware of all these things. So monitor progress of labor. You can do timely cervical assessment and then mark the partogram when they were beyond 4 centimeters dilated. So all these records should be there in your case sheet. So appropriate intervention when necessary. Like if you think it's crossing the alert line, it's crossing the action line, whatever should be done should be taught to the girls, and they should alert you. They should come and tell you what's happening, because they are the ones who are plotting the partograph for you. Okay. Then you should ensure that they have a respectful maternity care. You allow a birth companion with the patient right from the time that she is with you in labor, and you require her monitoring. Like suppose you have started oxytocin drip, it's always better to keep one person. It can be the husband, it can be the mother, it can be the sister, whomever she wants. You can make her sit beside her, and then, they will help you out also. If something goes wrong, they will call you. And besides that, your sisters can always monitor 2-3 of them in a row. So provide privacy in that labor room. So they have made sure that there are curtains. Even in government hospitals now, they have curtains between patients. So in a private hospital, you have no excuse to say you can have 2 people in the same labor room monitoring without any division between them. So you have to explain all the events of labor and the risks that are associated with each event that is not normal. So you have to take that patients to talk to them and give them all the details. And then you should take permission before anything that you do. Suppose you do a PV and then you decide that you are going to put in a drug for augmentation of labor or induction of labor. You should have spoken and taken permission from them before you do this. All this is called as respective maternity care, and you take them into this process of decision making. That is very, very important these days. So if they are with you, majority of the time, you are very comfortable. So you have to learn this and then finally put it on writing and get a informed written consent. Okay, then you maintain these 6 cleans for a clean, safe delivery. Or these 6 cleans are clean hands, clean surface. It should be a clean perineum. You should have a clean instrument to cut the cord. You have a clean cord clamp, and you should give a clean cord stump care. Episiotomy should be given whenever indicated. They are now trying to move towards no episiotomy era. But then whenever it is indicated, if you are not confident about delivering without episiotomy, I feel it's always safe to give an episiotomy. But you should give a local, tell them that you are planning for an episiotomy, give them an episiotomy and deliver. And you should wait for spontaneous labor. Don't hurry through and use a instrumentation till it is absolutely essential. So rapid is the initial assessment of the newborn is the next step that you have to be aware of. You put the baby as soon as you deliver on the mother's abdomen. You go and wait for delayed cord clamping. It can be 1 minute or 3 minutes as according to your wish, but then it should be followed in every labor room. 2 pre-warmed towels should be kept ready always to wrap the baby and take the baby to the radiant warmer. And you can, because you're holding the baby on the mother's abdomen and you're waiting for the cord to be clamped, you can use these towels to really rub those babies. Immediate drying and breathe assessment is very, very important. Later on, once it reaches the resuscitation corner, if you have a pediatrician or a trained sister who's trained in NALS, she will do all this head-to-toe examination and rule out congenital anomalies for you. But all these things are taught in Manyata as well. So the golden hour of breastfeeding should be insisted. So as soon as all these things are over, you can give the baby back to the mother. You can ask her to put it over her chest. You can ask the baby to crawl over her chest and reach the breast for sucking, and then allow the baby to suckle first. You can give vitamin K, OPV, BCG, hepatitis B within the first 24 hours of birth. So active management of 3rd stage of labor. This has been time and again been told to us, so all of us know it even in the middle of the night. But then this has to be inculcated into the sister's head who are with you in the labor room to help you. So you should examine the placenta fully as soon as it's delivered, so that you see if the membranes are all in full, whether the placenta, all the cotyledons are intact. Then only give the placenta to be disposed. Then give oxytocin. Make sure that the oxytocin is given within 1 minute after delivery. Use control contraction and then deliver the placenta. Give a uterine massage and check for bleeding. Okay. When there is an excess bleeding, it should be identified immediately. It may be immediately after delivery or within the next few minutes, hours, whatever it may be, but you have to identify at the earliest. So you should assess the uterine tone. When you do a uterine massage, most of us are able to pick it up much faster. The sisters are also doing much better than what we do sometimes. Assess blood loss. You can actually measure and then you should note it down. So this should be done as a practice. So only then it will register into your head when the blood loss is a little more than usual. This visual assessment is not really good because when you write down on your case sheet, for medical legal purposes, if it is in so much ml, it would be much more better than you tell that it was little more than usual. So I thought it was PPH. It should not be discussed or described that way. So 4th stage of monitoring is very, very important. So you keep the patient with you for the next 2 hours after delivery. You can either keep her on the labor cot itself or in some place in a soft bed closer to the labor room, so that you check BP 10 minutes after delivery, and after that every 15 minutes for the next 2 hours. And you look for bleeding every 15 or 30 minutes. If it's a little excess, you can always call the doctor and ask her to check whether everything is enough. Suppose there is sudden hypotension, shock, you will be able to pick up whether it is mild, moderate, severe, and all that, and you will start resuscitation also much early. So you should not miss this 4th stage of monitoring at all. So you should, when there is a PPH, you should be able to identify whether it is because of the tone, whether it is because of trauma, or it's because of the tissue. So we should be ready to handle all the three at any point of time. Severe eclampsia again, it's again been insisted time and again because these two, PPH and PIH, are the two threats always in for us to treat those antenatal mothers or the delivered mothers. So we should be aware of these things. You should record BP on admission. You can use a dipstick for proteinuria assessment in the labor room. You should be aware and look for convulsions if the patient is becoming a little also restless. You should be alert at all the time. And max self regime can be initiated immediately. That's what I told you. You should always have 20 ampules of max self in the labor room. At any given point of time, it should always be there. Suppose you have used today, you should make sure that the sisters replace before they change duty. Otherwise, the next duty sister may not be ready to replace, or she would not be aware that it has not been replaced. So we should never be in such a struggle. So all these things are, standard protocols that has been taught by the Manyata. So we get better and better every day because these girls follow these steps. Antihypertensive should be made available inside the labor room. Like you can have a few strips of Levitrol or 1 or 2 strips of Nicardia with you always. So you should put that also in that eclampsia box and keep it with you. Call for doctor, and special attention to the mother and the newborn should be incorporated into the system. So newborn resuscitation, the steps should be learned by all the sisters. You should at least have one NALS trained sister in each duty so that she'll be able to do quick resuscitation within the next 30 seconds after birth. And equipments like mucus extractor, suction apparatus, a shoulder roll, an ambu bag, laryngoscope, pediatric or neonatal laryngoscope, PT tubes, different sizes, 2, 2.5, 3. Everything should always be there in that radiant warmer. Underneath, there is a shelf. So you can keep all these things. And every time the sister gets that radiant warmer ready, she has to check if all this is in place. They should open the cylinder and see if everything is there. If you have a center line, they should open and see if there is oxygen that is flowing. So this should be taught to all of them, and they should be ready always for each and every delivery so that we don't get hiccups anywhere when we deliver an asphyxiated baby. Okay, preterm labor. So this again, you should identify the age of the baby, that is the weeks at which she has come to you in preterm, and you should ensure or make sure whether she has already taken steroids between 24 and 34 weeks. If she has not taken and now she's only 28 weeks and she's come with threatened preterm, you can give that, you can monitor. If she is 30 and you want to give neuroprotection as well, you should decide and give max self also for neuroprotection. And once the delivery occurs, if they are preterm or SGA babies, you should be aware that they can need monitoring about feeding, and you should initiate early feeding for these babies because their subcutaneous fat is very low, and so they may go in for hypoglycemia. So you should make sure that it is all done. And preterm babies, you have to teach, this is the easiest method that you can teach the babies to keep themselves warm. So you can teach the mother, kangaroo mother care, and you can give the mother the baby and ask her to keep the baby with her in the room itself. They will not require to be at the NICU. So universal infection protection protocol again has been one standard which they teach us. So here they teach us how to keep hand hygiene before and after each procedure. Instruments are supposed to be sterilized after each use. Labor table, floor, wall, baby warmer should be cleaned after each delivery. And what material should be or what solution should be used for cleaning. And biomedical waste segregation and disposal as per guidelines should be followed. Gloves, cap, mask should be worn in the labor theatre too. Disinfection protocol, that's what I was telling, all the disinfection. What you use and then what ratio they will do, all this can be written and plastered on the wall. So all the sisters know this, and even though they know it, every time they see it, if they are wrong for one time, they will correct at least. So you don't have to sit and talk to them every time. but still audit or your internal assessment should be done off and on. Okay, spill management should be implemented, microbiological surveillance. See, this swab test, see, they all insist, even for when they come for Clinical Establishment Act, renewal in Trichy, they were asking us to show only these two things. They were asking us to show if we have all the instruments which are sterilized, like do I have autoclave delivery sets. And then they were asking me about the swab results of the last 3 months. So they want us to do a swab every month. So it's very easy. If only we are trained in this Manyata, then we fall in line with all the other things, whatever are the other requirements. So medical establishment, clinical establishment act, yes, we are already following. So we'll get it without any difficulty. If you are applying for NABH, yes, we are doing everything. So we'll get it without any difficulty, all these accreditations. So in that way, it helps us to train our sisters. Okay, postpartum care and package at discharge should be discussed, and you should talk to them when you go every time on rounds. So you should do daily examination of this. Make sure there's enough secretions, whether the breast is soft or it has become already overfilled. All these things has to be seen. You have to check for the episiotomy, whether it's clean, lochia, whether it's healthy or not healthy. Look for involution of the uterus. And you should tell them to come and visit you after 7 days and again after 45 days. So these two are immediate postpartum period. This is the first postpartum period, and that is till the last. That is 6 weeks till the postpartum period is over. So all these things. And regarding the baby, you have to take care of the newborn feeding. You have to check the daily weight to make sure that the feeding is adequate. You have to check on the respiratory rate and the color of the skin, so that you pick up if anything goes wrong with the baby also immediately. You have to talk, and when you talk to the patient and when you see her herself, having seen her the 10 months earlier when she was pregnant, most of us are able to pick up when they are depressed during the postpartum period. And you have to give the necessary time to talk to them, try to give their emotional support. If not, at least refer them to the proper place, because these days girls have to resume back to their work. So that gives them a lot of stress. So all of them are baffled the moment the baby is born. Now the next question of when to join duty comes into their mind. So their happiness of having delivered, now relish the time of feeding their baby, looking after the baby, everything is gone, and there is a lot of stress about joining back work. Even if they don't have to go back to the office, they'll have to start working from home. So that is catching on most of them, and they are very depressed these days. So you have to take the time to sit and talk to all of them. Postpartum family planning should be discussed even before they get discharged. PPIUCD, yes, though it has been very commonly advocated in all the government medical centers, hospitals and peripheries, it has been very difficult for us in the private practice. But then I have now brought as a routine, I put it in the writing and give it to them after delivery the next day morning. No, this is before. That is about all the family planning methods. Now I give it to them the time they get admitted itself, and then get a consent from them. If they are willing, then we have started doing the PPIUCD. Yes, of course, some of them are ready. They do take PPIUCDs easily. But then this information is all that they require. So we have to sit and do this. And we have to talk to them about interval family planning methods that are available. So we put everything in writing and give it to them before they get discharged, so that they can choose and come back to us on the 45th day for family planning method. So again, for this cesarean section, standards are fixed. You have to identify the proper indication, give a proper information to the patient and her relatives, document it, follow and categorize them according to the Robson's criteria, obtain informed consent both for anesthesia and for the procedure. And you should have a proper OT facility, post-operative care, and the newborn care. And last line is very, very important, which all of us, especially in the private, refuse to do or have no time to do. We should sit and review the C-section rates every 3 months, so that we should know for ourselves whether all these cesareans were done for absolute good indicated cases. Okay, provide. This again is the standard for the facility, like what your hospital should have. So all these things have also been documented by them, and they give us, all this list, so that you make sure that your hospital has all these facilities. So it should have a laboratory facility. It should have a place for registration, for consultation, and IP admission areas. You should have a proper MOU with all your referral centers. Suppose you are sending the patient for ICU care elsewhere. You should have a good MOU with that hospital so that they will not refuse at any point of time patient coming from your place. You should have a safe, secure infrastructure as per the norms. That is, like, you should have adequate space. You should have a good OT infrastructure. You should have entry protocols. You should know where they should come, whom they should meet when they come, even in emergencies. Then you should have good water and electricity supply, safety, security, newborn safety. Like, when you go for NABH, they will teach you all this pink color, pink code. Then you should know how, you should be ready if there is a stealing of the baby. So for that, you should be prepared. So all this is taught even in Manyata. That's what I was saying. So it's very easy to get yourself accredited by the NABH. And you should make sure you have a clean environment. So again, there should be a very ease for information to care seekers, attenders, and the community about your place. So you should have good displays. You should have good signages, like where to go, how to turn to reach the labor room. All these things have to be put up everywhere. And then you should provide patient education slips. Like, we think that this is too much, but when you give that, half the questions are done. So they read that and they are happy. So they will not be asking you and nagging you. So all these things should be done appropriately. And then the ambience should be very pleasant for anybody to be with you there. So regarding the equipments, instruments, and program for maintenance and calibration, all this should be maintained. Because once you have an instrument, you should know how it is being calibrated, and you should get a certificate every year about the calibration. And you can have an annual maintenance contract for all the equipments that you have. Suppose you have a ventilator and you have not been maintaining that. The day of emergency, it will not work. So you should make sure that all these things are maintained in a proper way. And they give us one record book on which you have to write everything. So everything has been done so systematically, you are not stuck anywhere. That is what is the best part of being trained by Manyata. So you have, again, you learn about how to store your drugs, your linen, your consumables, all your high alert medications, how they should be kept separately, how they should be handled. Then how you give your prescription, drug administration for the sisters. When they even do an IV line, they should know how they will clean the place, how they will do, how they will talk to the patient before they give the IV line. All these things are very good things. And suppose they give a drug and they develop an allergy, then this is called as adverse drug event, and how they will manage the situation. This can be done repeatedly for them. And then, like a, what should I say, role play. And then they repeatedly do that so that the others also learn it very easily. Blood safety protocol should be done. So now, patient identification, verbal orders, handover and takeover, high-risk patient management, informed consent, information sharing, all these things should be there to give all the details to the patient, and it should be maintained in good case sheet forms. So clinical record maintenance, again, you should have a good case record, operative notes, and death records, which should be maintained for at least 5 years. Qualified and trained staff training, refresher training should be implemented in all the places so that all of them are upgraded every now and then. Safe staff adequacy should be checked. And if they are dropouts, then you have to fill in those spaces. Evidence-based standard treatment guidelines, you can create your own SOPs and make it there available in the labor room, in the operation theater, everywhere, so that everybody is aware about it. And then you offer them training now and then assess the clinical competence of all of them. That's what I was saying. So you have to do repeated drills now and then. And you should take care of your staff's health as well. So you can take a medical checkup every year, give them this HPSAG immunization. Suppose you think influenza is rampant, you can give them flu vaccines. Things like that should be offered from your side for all your staff. So quality, clinical care, safety, and quality indicators should be maintained. So indicators are with respect to the performance, and these are supposed to be maintained. Like they will say about, when you use catheters, urinary catheters, if you have catheterized the bladder, they will ask you to recall and see for the whole month how many UTIs you have had following a catheterization. So something, if it is much more, then they know that you have to make yourself better when you put in the catheter. You have to clean the place, like how they are doing. This has to be taught to them again and again. So such things have been very, very helpful for the sisters. So patient satisfaction can be measured as your quality clinical care when you get a good feedback from them, and you have SOPs. So that will help you to definitely maintain a good clinical safety for all your patients. Internal assessment will tell you whether your sisters are working good. And audits every 3 months will say your quality of work as well. So pre-operative assessment, monitoring during surgery and anesthesia should be again maintained. You have all these forms with you. Pre-op assessment, pre-anesthesia and anesthesia services, all those sheets should be in place. You should have, the patient's identification written either in a tag, or you can put it on their forearm and then send them into the OT. During anesthesia, post-operative care and handover and takeover, all these things should be done by sisters in a systemic manner, and this is being implemented or taught to you by Manyata. So Manyata is a regular ongoing accreditation program. It is connected to NABH now. They say for NABH, if you say you are a maternity nursing home and you have Manyata accreditation, NABH, getting NABH seems to be a little easy because they now have a tie-up. Foxy has made sure that they have a tie-up with the NABH. And now in Maharashtra alone, they have linked it with Lakshya. So whatever Manyata was lacking from Lakshya, what they expect in Lakshya, that has been incorporated now. And, if I'm a private practitioner in Maharashtra, I can say my center is Lakshya Manyata accredited. So that way we have edges, or we have a good recognition by the public. So that's a very good thing. So specific standards has to be maintained by this unit for providing good care for the mother and the newborn. So I hope I'm clear about what Manyata would mean to each of us and how it would help us in doing our private practice and having a good setup to help all the mothers, because our major aim is to bring down the maternal mortality and infant mortality. So I think this is a very useful training program that all of us should take and allow, or when we have taken, we should ask the others to also get their centers accredited by Manyata. Thank you very much for your patience. Thank you, madam.
Thank you, Chitra. Excellent talk. You have put it in nutshell, entire thing about Manyata and entire maternity, respectful maternity care itself. And I'm sure all the audience who are attending today those who have not yet got certification will definitely apply for and do it, and also spread this message to other private sectors too. This is such a very, very useful thing. Many times during this Manyata training, even the doctors themselves, after attending, they say that many new things, in which we had a lot of doubts, we got it cleared. So it's really a very, very useful thing, and you have put it in a very nice way. Thank you very much.
True, madam. After all the training programs, even the girls will come. What they were so long scared of asking us, they will come to us and at least clarify everything within us.
Yeah.
They will come straight to us and ask us all these doubts.
Yeah.
And when they are doing it every day, they are very happy. Thank you, madam.
Nice, nice. Thank you. Thank you very much. Thank you. We can, Gayatri, we can move on to the next thing.
With this, we come to the end of this session. Dr. Radhika will now introduce the moderators for the panel.
Radhika ma'am, please unmute ma'am.
So coming to the last session of today is a panel discussion on heavy menstrual bleeding. The moderators are our Dr. Vidya Prabhakar ma'am, who is the president of Tnfog. She's the clinical director, chief consultant of
Enough. I've already been introduced.
Okay, ma'am. And the other moderator is Professor Dr. Shanmuga Vadivu, Professor of Department of Obs and Gynae, Government Mohan Kumaramangalam Medical College Hospital, Salem, and she's also the Vice President of Obs and Gynae, Salem Society, 2024. And she has 18 years of appreciable service to our medical field, untiring teaching experience for both UGs and PGs. And she's published indigenous articles in national and international journals, and she has a special interest in the field of high-risk obstetrics and endoscopy. Welcome, Professor Shanmuga Vadivu. And she's also my postgraduate batchmate. And I welcome Dr. K. Shobana Priya, who who is Associate Professor, Bharat Medical College and Hospital. She's a member Clinical Research Committee, FOXI 2022 and 25, and founder member Kanjipuram OG Society, immediate past joint secretary of IMA Tamram, and she's the best service provider in PPIUCD insertion in Chengalpattu, and also in Doctor's Day Special Appreciation Award by Chengalpattu Medical College and Hospital in 2022, and she's won the Best Doctor Chengalpattu by District Collector in 2023. Her special interests are in high-risk obstetrics, gynae endoscopy, and gynae oncology. Our other participant is Dr. Priya Kannappan, and she's senior consultant from Dr. Mehta's Hospital and GFC Fertility Center, Chennai. She is a best outgoing student, and she was Best Resident Award from Manipal University, and she's underwent fellowship training in ultrasound, reproductive medicine, and laparoscopy. She's an active participant in FOXI quiz committee and conducted PG quizzes in Oxycon 2023, Tnfog 23, and TAPISA 2023, APCON 2024, and also in the SouthCon BP conference in 2024. She's also an active participant in FOXI clinical research between 2023 and 24, and she's organized monthly journal club webinars. And she's a master trainer in FOXI HPV vaccination training program in 2024, and also an executive committee member of FOXI between 2021 to 22, 23, 24, and high-risk obstetrics is her interest, and also infertility. Our next panel member is Dr. Gayatri, who is our moderator, who is done her UG from Chengalpattu Medical College and Masters from Raja Muthaya Medical College. And also she's done her PG DMLE from National Law School of India University, Bengaluru. And she has a diploma in gynae endoscopy from Kiel, Germany. And she's a consultant of Shamla Nursing Home, Trichy, executive member of Triox and South Zone coordinator of Ethics Medical Legal Committee, FOXI. Her area of interest are high-risk obstetrics, infertility, and medical law. She's presented papers in ACOG, FOXI, and been a faculty in these conferences. She's authored chapters in FOXI Focus and other textbooks. Welcome, Dr. Gayatri. And we have Dr. Christy Kulathina, who has done her MBBS from Sri Narayana Institute of Medical Sciences, Ernakulam, Kerala, and Dippan from Edapal Hospital, Malappuram, Kerala. And she's cleared at Part 2 MRCOG. Work experience as a senior doctor in Sri Muthukumaran Medical College Hospital and Research Institute. And also she was a senior registrar in the department of Dr. Rela Institute of Medical Center in Krompet for 2 years. And also she was a JR in Government Medical College, Konni, Kerala. And she also worked at CMAR Center. Dr. Vijayalakshmi Madam is our other panel member. She's an assistant professor from Government Dharmapuri Medical College, Dharmapuri. And she is from Coimbatore Medical College. She's done her MS from ESI Medical College in Chennai. And she's an assistant professor. She was working as an assistant professor from 2014 to 18 in IOG, MMC Chennai, and has 11 years of teaching experience. Also trained in gynae endoscopy, special interest in infertility endoscopy, high-risk obstetrics. And also she was an organizing member of Gestos Conference in Hosur, and she's a treasurer at OG Association of Dharmapuri. Welcome, and I am also one of the panel members.
We have with us Dr. Radhika Gauri, who is also the second other coordinator for this program. She did her DGO from the MMC Chennai, and she has more than 10 years of experience working in the US, UK as a registrar. And she's been trained in laparoscopy from the World Laparoscopy Center, MRCOG, with more than 20 years of clinical experience in OBG. She's been the coordinator in 2023, and she's also one of the moderators for this program now. And she's a member of a lot of committees, FOXI, RCOG, IMA, and her special interests are in high-risk pregnancies, adolescent obesity, and MAS are her special interests. Thank you for joining. Over to the moderators now.
Okay, good evening all. I'm extremely happy to welcome my co-moderator, Dr. Shanmugavadibu, and all my list of esteemed panelists. I can see that all of you have a lot of credentials. All of you have a lot of years of experience and in teaching field as well. So it is going to be a cakewalk now. Okay, so I think I'll let the panelists only do all the talking. Can we have the slide sharing, please? Yeah, I welcome all of you. Can we go to the next slide, please? Okay, now before we go to the next slide, so our topic for today is actually heavy menstrual bleeding, right? Now, what do you think is heavy menstrual bleeding? Can I have the first panelist answer that question?
Good evening, ma'am, and good evening. I thank Sambat Kumari madam and the Tnfog team for inviting me and giving me this opportunity. Thank you, ma'am. And to start on with, heavy menstrual bleeding is an excessive bleeding which actually affects the quality of life. It is not no more the quantity. It is the whenever it is affecting the quality of the woman's life, then we attribute it to the heavy menstrual bleeding. And
Very
it
right.
affects.
Very right. You hit it on the nail, actually. So earlier we were saying 80 ml, 75 ml and all that. But nowadays it is not just the quantity, and it is not very easy to measure the quantity also, isn't it? But suppose somebody is having only 2 days bleeding normally, and somebody is now having 5 days bleeding, which would be considered normal for another lady with 5 days. But for her, that from 2 days to 5 days, it has increased. That will also become, that will also affect her life. So it is no more 80 ml. It is the kind of bleeding that affects their physical, mental, or social, or economic well-being, whatever. So if it is affecting all these things, then definitely it should be considered as heavy menstrual bleeding. Right, very right. Thank you very much. Can somebody else tell me about the palm coin classification before we go into the case?
Okay, so palm coin usually we divide it as palm, which contains the structural factors, that is the polyp, adenomyosis, leiomyoma, and malignancy and hyperplasias come there in palm. And then we have the coin, which are more of like functional or the blood parameters, like, all the coagulopathies, ovulation, endometrial causes. So the other part comes in coin, madam. So we usually try to classify based on palm coin classification. And again, with myomas also, we classify as like what type of myoma, so that it's easy for us to formulate a management according to the patient's need.
Right. Thank you very much. So that is very nicely put. So we all follow this palm coin classification now. Okay. With that, I think I'll hand it over to Dr. Shanmugavadivu to take over the first case.
Thank you, ma'am. First, we'll move on to, we'll start with the adolescent puberty menorrhagia. So coming to this case, she is a 16-year-old, attained menarche 2 years back, has complaints of continuous painless bleeding PV for the past 10 days following 2 months of amenorrhea. And on examination, she's pale, but her abdomen is soft, and her hemoglobin is 9.1 and platelet count was 2.4 lakhs. Her bleeding time and clotting time was normal, and the thyroid function test was also normal. And she had an ultrasound report which revealed the uterus is normal size, and his ovary shows polycystic, multiple small follicles, and there is no free fluid. How will you go about this case? Next panelist, who is going to take up this case?
I will, ma'am.
Yeah, please go ahead.
Girl, only 2 years since menarche. Usually, the hypothalamo-pituitary axis is quite this time. So we can just, since she's a very small girl, we have to be more detailed in her history taking, that she doesn't miss anything. And usually these are anovulatory bleeds. And once, especially when we have the hemoglobin, which is lesser, it's better we evaluate her so that she doesn't really become anemic because of the blood loss and other things.
So, but we should have a detail, I think we should have a detailed history taking because she's a young girl. So we can't ask whether the bleeding is heavy like that, but we should put the leading questions like how many days you are bleeding, and how many pads you change, or you experience any flooding or gushing of blood, or she's changing the pads every 2 hours once, and whether it is associated with clots. All this indicates that the bleeding is heavy. And also you can ask about any previous treatment for anemia. And to main thing is in the adolescent age, we want to rule out about the bleeding disorders. So I think you can ask the leading questions regarding the bleeding disorders, like any history of bleeding gums. Previous slide, Shripriya, previous slide. History of bleeding gums, any epistaxis, and any history of bleeding following tooth extraction on any surgeries, and mainly any family history of bleeding disorders. So anybody can say about that pictorial assessment of blood loss? Next slide. Pictorial assessment of blood loss, PBAC scoring.
No.
I think Shanmugh, you can go ahead and please say that.
Yeah, because I think this is mainly very useful for the adolescent girls. So with the amount of blood soaking, we can assess whether the bleeding is heavy or not. So this goes with the when they are using the sanitary pads, when it is only slightly stained, we give the score of 5. And when it is score of 1, when it is moderately stained, we give a score of 5. And when it is completely soaked, we give a score of 20. The same goes with the tampons, but it is less 1, 5, and 10. So the total calculation is when the score is less than 100. So for the number of days we calculate, when the score is less than 100, we say it is normal or light bleeding. But when the score is more than 100, we say it is heavy bleeding. So each day the girl has to mark the score, whether it's 1, 2, or 3. For the 7 days, she has to mark. So based on this, we can assess whether the blood loss is heavy or not. So it will be useful for the young adolescent girls to assess, so we can know whether it is menorrhagia or not. Next slide. So what are the common causes of AUB in this age group? Can anybody say?
Yes,
Panelists, yeah, in pubertal age group. Radhika?
Yeah, it could be even pregnancy. Irregular bleeding can also be normal pregnancy, intrauterine pregnancy, or an abortion. Sometimes they take the medications from outside, so it can be retained products also. An ectopic pregnancy also you should consider. And apart from the non-pregnancy causes, could be thyroid disorders, and as you said, polycystic ovarian disorders, bleeding, coagulation disorders. And infection is also a common cause. Even if they're sexually active, it could be chlamydia also, and immature hypothalamo-pituitary ovarian axis.
So we go, the first common is the immature hypothalamo-pituitary axis, then the endocrine causes, then the bleeding disorders. Then we go about PCOS, infection, and pregnancy-related causes. So based on this differential diagnosis, we will go with the investigations. So anyone? Next panelist, what are the investigations you want to do? You want to say? Anybody?
Yes,
any panel?
First, they'll have to do a complete blood count, ma'am. That will give us idea about how much of blood loss she's having, what is the hemoglobin, what are platelet counts like, whether it's iron deficiency. So complete hemogram. And if she's an unmarried and a young woman, so examination may not be really helpful. Though if we really suspect something, we can ask for a rectal. Otherwise, an ultrasound will be good enough. A transabdominal ultrasound. Thyroid function test, because that seems to be quite common nowadays. And to rule out other coagulation disorders by coagulation studies.
Yeah, can I put in a word here? I just wanted to mention here. So in this young age, like for example, this is a 16-year-old girl. She is probably, immature hypothalamo-pituitary ovarian axis. So in this, probably the ultrasound would come a little later. So sometimes when they come to your OP, I don't know, what do you do in your OP when they come first?
Usually, I never ask for ultrasound, madam, because the only thing is when you do the ultrasound in these young women, I mean, these young girls, like, per se, everybody will have a multicystic appearing ovary, and immediately they will give a diagnosis of polycystic ovarian disease. Though we all recommend say that less than 18 years, you should not diagnose PCOD. But every scan done by a radiologist will come with a report saying that she's a PCOD. And then it gives a lot of fear with the women, I mean, the girl as well as the mother.
I agree with you. I agree with
Yes,
you,
the only thing which I would like to... Yes, the only thing which I would like to see in an ultrasound, sorry ma'am, if the only thing which I would like to see in an ultrasound is, if at all, is there any ovarian cyst or a ovarian tumor, like, maybe a very rare scenario, maybe something happening, estrogen secreting, or that is what, if it's in mind, then that is a reason. Otherwise, that will definitely not come as a first place.
Not only that, I think they also pointed out pregnancy-related causes. If you are suspecting anything like that, once again, probably. But when they come to you with a typical history of heavy menstrual bleeding, I think probably you would start treating her, after doing the initial blood investigations, and then start treating the anemia and start treating the blood loss, right? Maybe in your second or third visit, ultrasound will also come, unless you are suspecting a pregnancy-related scenario or a malignancy, like you said, but that comes actually rarely, right?
Yes.
Okay, let's proceed with the next then. What even?
Yeah, so Madam said we go ahead like this. Urinary pregnancy test also. We should ask the history when nowadays even in our country the pregnancy unwed pregnancy is so common. So always you have a doubt, you do a urine pregnancy test. Then as we said, lastly we go for the ultrasound abdomen and pelvis. You generally go with the transabdominal ultrasound. And if you have signs of PCOS, so if the patient is really, she's having obese, hirsutism, acanthosis, all this, then you go for further testing for PCOS, or else it is not needed. So next slide. So how to manage? So main thing is how to treat the anemia and the how to stop the bleeding. How to stop the bleeding. So I think this is a little bit of algorithm. So I think main thing, the patients come with the history of heavy menstrual bleeding. Mainly they come with the acute onset of bleeding. I think in a government setup, we face many cases like this with acute onset, severe anemia, and continuous bleeding. So how to, you generally go with all the investigations, then how to stop the bleeding. So how generally what you give? So we go with the tranexamic acid. We can give the tranexamic acid, or you can give mefenamic acid. And to stop the bleeding immediately, you go IV tranexamic acid, or you give estrogen therapy or progesterone therapy. So you give a high dose progesterone. So you give a medroxyprogesterone 50 to 60 to 80 milligram BID until the bleeding stops. Or if you can go with the estrogen therapy. So estrogen, I think generally we are not using here, but we can use Primarin 25 milligram IV every 4 hours when the bleeding is severe. And generally they will be having severe vomiting. So to stop the vomiting, along with that, you have to give the antiemetics. So once the bleeding stops, then you give the maintenance therapy. You should not stop with that, because again you will have the withdrawal bleeding. So maintenance therapy can be it will be better. You can give a progesterone. You can reduce the dose 10 milligram BD or TID, and then you can give up for 21 days. Or you can go with the continuous oral contraceptive pill. So combined pills also you can use. So either you give combined pills, or you go with the progesterone only pill. And the main thing is at the time of discharge, you ask the patient to continue the hormone pills. Many times they will stop, and then again they take for 1 week. Once the bleeding stops, they will stop the treatment. Again, they will come with the withdrawal bleeding. So give a proper advice that they should continue the pills. And also the treatment of anemia is very, very important. So if the hemoglobin is more than 7, you can give them with the oral hematinics is enough. But when the patient, when she's coming with hypotension or with the severe, when the hemoglobin is less than 7, you have to go for blood transfusion. But you have any hematological disorders, you treat in consultation with the hematologist. You have a lot of hematological disorders like ITP, von Willebrand's disease. I think it will take a lot of time to discuss about this. So based on the what hematological disorders are in concurrence with the hematologist, you can treat with either with the platelets or with the von Willebrand's factor or with the desmopressin's nasal spray, depending on what type of hematological disorder you have. I think the treatment is mainstay is tranexamic acid and then progesterone, or you can give estrogen, and maintenance is continuous oral contraceptive pills. Ma'am, you want to add anything, ma'am?
I would like to add one point, ma'am,
Yeah,
because
please tell.
since 16 years, we usually see many girls at this age with a very high BMI. That is the one thing which we have to really encounter, because
Yes.
the BMI for this patient we may not know. So every time the patient comes with a weight of far extremely high, and because of that could be because of the sedentary habits or the change in the food habits, or because of the late night sleep, or they using the increase the mobile phone, whatever it is. Yeah, junk foods. So these lifestyle modification has to be incorporated, not just with the medicines, but it has to be we have to strictly advise them to follow this lifestyle
Absolutely.
Yes.
Absolutely right. That is one of the first things. Can we have the next panelist? Can Dr. Christy, I think, can you tell us exactly what do you follow in this kind, when a girl like this comes to you, what is the kind of treatment that you give up? We'll leave alone the investigations. What drug therapy do you give usually in your practice?
We give progesterone, high dose of progesterone, tapering dose, ma'am.
Yeah, you just tell us what dose you give.
Yeah, we give for the acute bleeding, we give with the tranexamic acid. We start with tranexamic acid. Then we follow up with the tranexamic acid. We give, it's a very acute bleeding, we can give 1 gram IV or then controlling, then we will go with oral tablet. Then we will tapering dose of progesterone like 10 mg TID, then TID for 1 week, then BD for 1 week and OD for 1 week, and review on the next periods. If she settles with bleeding, we can discharge her with this maintenance dose.
So you're talking about medroxyprogesterone, right? Anybody else is giving any other progesterone?
Norepinephrine.
Okay, so what is your dose?
I will, like, after giving the tranexamic acid, I will start on with 10 mg TDS. If it is very high, even at 20 mg, then tapering down as a medical fractional curate, like 10 mg TDS, then BD and OD and alternative. And then next cycle, probably I will start on with dosicils along with lifestyle modification.
So what, do you encounter any problem when you give this kind of dosage? With the patient?
The patient most of the time, they don't adhere to what we tell. They will stop in between and they will, come back with again a rebound excessive bleeding again.
That is why Dr. Vadibu also said, because the maintenance is very important. Dr. Shanmuguri was saying, isn't it? Because many a times you find that as soon as the bleeding has stopped, they will stop. They'll stop it. Okay, that is one thing. So
and the other thing is we have to just give them a top up that, whenever you give these kind of progesterone, especially the norethistone, madam, they really form a very good decellularized endometrium, and when they shed it, it's really painful. So sometimes they get these white kind of pieces, some people even get scared telling that, they've got an abortus coming out. So they extremely painful when it comes out. So just you have to just give them a reassurance
need to give some painkillers. You need to tell them that it might be a painful period and you have to give them painkillers just in case when they start bleeding. Exactly. Very right, Dr. Priya.
And especially like whenever they have anovulatory cycles, so they have never been exposed to progesterone. And when we give a very efficient progesterone there, then the periods become really painful.
Okay. Dr. Vadivu, can you sum up this case?
Yeah, I think puberty menorrhagia, we go with investigations. Mainly, we have to rule out the hematological disorders, and then we have to rule out the endocrine thyroid dysfunction. Lastly is the PCOS. Then, based on that, we do all the investigations. And the main thing is how to stop the bleeding and how to make the patient adhere to the treatment. So generally, we go with the progesterone, high dose progesterone initially, followed by tapering dose of progesterone, or high dose estrogen followed by continuous oral contraceptive pill, and simultaneously treat the anemia also. You forget about treating the anemia. Always you give the iron supplements when the patient is getting discharged. And main thing, lifestyle modification, as all the other panelists said, you advise them weight reduction, and then advise them to continue adhere to the treatment and report to you to the next cycle. Because they will be getting the over-counter, they will show the prescription and go on getting the treatment. So ask the patient to come to you to the next cycle, and based on how the amount of bleeding, you can give either oral contraceptive pills or the progesterone from day 1 to day 25, based on based on their adherence, we can modify the treatment. We'll move on to the next case, ma'am.
Yes, very well said. Okay, next case. Okay, now let us move on to the next lady, Mrs. X, 45 years, para 2, living 2, previous normal vaginal delivery, sterilized. Complaints of excessive bleeding PV during periods for 6 months. Has 7/30 day cycle associated with passage of clots. Also has complaints of pain abdomen. So before we move on to the examination, what does it tell you? The moment you heard the history, before you put a hand on her, what do you think of? Can we have Dr. Vijay Lakshmi?
Yes, madam. Patients complaints of pain and also dysmenorrhea. So there may be diagnosis of possibility of we are dealing with adenomyosis or fibroid uterus. We can have the diagnosis.
Exactly. So that is your diagnosis in mind. Okay. Now on examination, this patient had mild pallor. Per abdomen, it was soft. Per vaginal, uterus anteverted, 12 to 14 week size, bulky uterus. Okay. So what do you think now?
But still it could be adenomyosis or fibroid uterus.
Okay. So how do you proceed with her investigations?
So we can do to confirm the diagnosis, we go for the ultrasound, madam. By ultrasound, we can diagnose whether it's adenomyosis or fibroid uterus. We can easily diagnose.
Okay,
And,
so in these cases also, like in the previous case, we should not neglect the anemia as well. So we should also start doing the CBC, okay, complete blood count, and of course thyroid once again. So, and then the bleeding disorders also must be kept in mind. At least you don't do a detailed one, at least BTCT can be done if you really think. And then of course ultrasound, which clinches your diagnosis, right? Okay, now this case showed an ultrasound report of bulky uterus with 4.5 into 4 centimeter fibroid in the anterior wall and 2 into 2 centimeter fibroids in the posterior wall. So any other information you require from this?
The distance of it from the endometrial cavity, madam, the fibroid in relation to the endometrial cavity.
So you would like to do a fibroid mapping in this case, isn't it? Because there are 2-3 fibroids. So you would like to do a fibroid mapping in this case. Okay. So now that brings us to the palm coin again. So this is a structural anomaly. So, I mean, not anomaly, structural problem. What are the possible causes of AUB in this age group? So the structural causes are endometrial or cervical polyp, adenomyosis, fibroid. Now, in this, we have zeroed in on adenomyosis or fibroid because polyps very often have some intermenstrual bleeding or irregular bleeding as well. Now, in this patient, it's a very regular cycle of the heavy menstrual bleeding, right? Then infections like all these infections are possible. Endometritis, chronic endometritis and tuberculosis is something we need to remember as well. Because I think many of us tend to forget about tuberculosis once we leave the medical college. But I think that is also rampant. Okay, then comes malignancies, endometrial or cervical, medications, blood thinners. Yeah, this is another thing we need to remember. Many of them are on blood thinners. They would have undergone cardiac surgery. So the anticoagulants might be there and all these aspirin and HRT. Now, again, some of them might be, on this replacement therapy, tamoxifen, IUCD. Yes. Now, that's another thing, many times that brings us again to the same problem. PP, IUCD, sometimes it is inserted without the patient's knowledge. Then what happens is patient doesn't know and there might be bleeding. So that once again, your ultrasound will definitely give you the clue apart from your clinical examination, right? And then pills.
Endometrial thickness also.
Yes, and their pills and injectables could be also the reason because they've been taking it irregularly or taking over a long period of time, all those things. And then other medical conditions. Again, as I said, the coagulation disorders also should be kept in mind. We cannot think that only adolescents. Even at 45, we should still think because there might be things like ITP, which comes suddenly and, so it might have been missed. Okay, so
something like drug-induced ITP we can have, and I think I had a case, ma'am. Actually, she presented with AUB and she went somewhere and got hysterectomy done, and later she was diagnosed to be having leukemia. So from that onwards, I go with CBC. I do a peripheral smear. Always I do a peripheral smear.
So CBC, if there is anemia, definitely it warrants a peripheral smear. This can happen actually, and many times ITP presents as a menorrhagia actually. I have seen so many people with ITP just presenting with menorrhagia. In fact, reproductive age group also. They would have had menorrhagia earlier also, but then, heavy menstrual bleeding, we shouldn't say menorrhagia, heavy menstrual bleeding, but it's been there earlier, but she never noticed. Suddenly it is very high and then she comes. Okay, so what investigations can be done? Can I have the next person?
Yes, so complete blood count, bleeding time, clotting time, the thyroid function test,
exactly,
and ultrasound, and obviously we should do a speculum examination and do a pap smear, look for a polyp and other things, and also a culture. Even gonorrhea, chlamydia, all these PID infections can cause bleeding, and saline infusion sonography can be done.
I would like to know, Dr. Radhika. Yeah,
Yes,
Dr. Radhika, do you routinely do all these cultures? This chlamydia and gonorrhea cultures, do you routinely do?
If there is a profuse discharge, we go for a culture, ma'am, not routinely. But in the UK, we do. Yeah, in India, we don't do. But in UK, we do routinely chlamydia and all the things.
No, I'm talking about India. We are right now in Tamil Nadu.
Yeah, India only if it's profuse discharge, we do the culture.
Yes, if you have some kind of history like that, similar suggesting that, then yes. Otherwise, we are not doing all the cultures.
We don't do the cultures.
But pap smear definitely we do.
We do.
Yeah, we do the pap smear definitely.
But we actually, now what is add on HCR, sometimes we do a CRP, which can distinguish between, if we suspect infection, we sometimes, although it is not conclusive, but it gives us some idea.
A point. Suppose you're suggesting, if you're thinking it is probably a PID or something like that.
Husband's
yes.
job and sexual intercourse, those histories we take in detail. And if we think it's an infection, especially younger women between 30 to 40, infection is also a common cause. And nowadays, because of PCOS, diabetes is also a predisposing factor for infection. So if we treat them with antibiotics, then obviously the menorrhagia subsides.
Okay. Okay, that is fine. But now in this particular case, we are thinking
Yes.
about either fibroid or adenomyosis. Right? This is
Yes,
a 12 to
ma'am.
14 week size uterus. That doesn't mean we are not going to think about infections. Yes,
Yes,
definitely yes. But the ultrasound here is saying either in the ultrasound is given a fibroid. Now, so what is the status of the saline infusion sonography? When do you do it?
When we
So
suspect
if
some
we polyp
cavity, submucous
deletion.
Yeah. So you find a thickened endometrium, or you find something which is looking like a submucous fibroid, you're not very sure, you want to delineate. Yes, saline infusion sonography, or even polyps can be very well delineated with that. All
But
right.
MRI is also enough, isn't it, ma'am? MRI, abdomen and pelvis.
So MRI abdomen and pelvis is actually, I think, I don't know which is costlier. I think MRI pelvis will
MRI
be
is
costlier
costly,
than
madam.
saline infusion. And also, it may not be there in your own clinic. You see,
Yeah.
saline infusion sonography, you can do it if you have an ultrasound machine, right? You will not be able to do an MRI pelvis yourself, right?
Yes, but
Okay.
whatever is depending on the availability.
patients are better that way, ma'am.
Yeah.
So
What is
when
that?
you
Think they are better, they accept that better than this.
So when you suspect any malignancy, when you suspect a malignancy, or when you are planning for myomectomy, in that case you can go for MRI pelvis, or else MRI pelvis is not needed.
Mostly
And
about
also,
ultrasound,
in
they
those
will
cases,
Infections,
suspect-
I think saline infusion may not be a possibility. If we, yeah.
You can go for endometrial
all of
biopsy.
these investigations, they
Give us
have
a
a place.
conclusive diagnosis, then we can go for MRI.
Yes.
Okay,
a good
so
DEXA
right.
scan gives a better, whether we have a polyp or fibroid. Polyp can be taken in a good previous scan as well.
Yeah.
We need not even rely on the radiologist. We can even do a better scan and pick it up with even a small
Yeah,
size
a
polyp.
good quality 2D TVS itself is good, better. I mean, one thing is the patient BMI also makes a difference. If it's a very heavy patient, even with TVS will not be able to pick, even with a higher end quality machine. And sometimes higher machines, like you see it very clearly with 2D itself. And now most of the centers, we even have 3D. So once 3D is there, I don't think we need a saline infusion. If you have a 3D, you can just go to sleep there.
Yeah, 3D is pretty good, but then saline infusion has its own place when you really want to delineate, and how much of it is inside the cavity, is a mucous fibroid. All these things are better delineated with the saline infusion. So everything has its own place. And then MRI pelvis, as far as MRI pelvis is concerned, it's in my experience, I found many times an MRI interpretation is very, very important. Sometimes I find the 2D sonography is much better than the MRI if it is not done at a good center. That is also there. But then MRI has its own place. If you are thinking in terms of an ill-defined endometrium, if you are thinking in terms of malignancy in those cases, and you really want to know which one it is, then yes, definitely it has a place. Now, the next investigation is endometrial biopsy and hysteroscopy. So what do you think? Who is the next person in line? I think Dr. Gayatri or Dr. Who is the next one?
Dr. Christy, I think she can
Dr.
answer.
Christy? Yeah,
She's
can we have
silent.
you? Dr. Christy, you're there?
Yes, ma'am. Yes, ma'am.
Yeah, so do you get an endometrial biopsy done in these kind of cases, pipple biopsy, or do you go for a hysteroscopy? What is your plan of action?
First, we will go for a pipple, ma'am.
You go for a pipple. So how many of you agree with the pipple? How many of you would like to go straight away for hysteroscopy?
If it is a 12 to 14 week size, I think it's feasible to go for a pipple.
I would like to go for an hysteroscopic biopsy, ma'am. I would like to see what it is and then take a biopsy.
Hysteroscope, ma'am. See it and test it. But in case we don't have the, the facility, or we don't have the office-based hysteroscopy, then maybe we can settle down for pipples.
No, I think we should individualize based on the patient. Suppose if she has a additional risk factor, for example, a family history of malignancy sitting on there, then I think you will not choose anything else rather than hysteroscopy. If suppose some other person is having either an endometrial or an ovarian CS, so then we are directly going in for hysteroscopic biopsy for this patient. Otherwise, and As a thin endometrium, I would I will not consider a biopsy at all for this woman.
Exactly,
I mean, if it's
exactly.
thin endometrium, I will definitely not need it at all.
See, if you have got a good
younger.
ultrasound picture and you are able to delineate the endometrium very clearly and the endometrial cavity is perfectly otherwise fine except for this one fibroid which is jutting in from one side, otherwise everything is fine with this endometrium, then I don't think there is any need for going in for that, unless you want to do it for some completion sake, in which case an endometrial biopsy, simple people will be enough, rather than subjecting her to a hysteroscopy, which is one more surgery, one more procedure, which escalates her cost as well. So, but if you have an endometrium which is suspicious, then yes, hysteroscopy would be the first line of action.
Yes,
we are talking
and
about
even
this
otherwise, like if the patient history says like a period of amenorrhea followed by bleeding, then should have something in mind, because we are looking at a complex hyperplasia. That is what I feel. Whenever they give a period of 3 months, 4 months amenorrhea followed by heavy pouring, then most of the time the comes there. Hyperplasia will be there.
Yeah, in those cases, but then even then, if your ultrasound is very
Endometrium,
clear,
yes, your endometrium thickness decides, madam. Agree with you.
yes. So the whole picture of endometrium will give you the clue which one you want to proceed with. Okay, so let's go down to the next management. Yes, Dr. Shobana Priya. Can you tell me how you're going to manage this patient? You've done the investigations, you've got the fibroid, there is nothing in the people biopsy, everything is normal. So what are you going to do for her? She's 45-year-old, she's finished her family. What are you going to do for her now?
I would like to discuss with the patient regarding the treatment, madam. So I will look at give the all the options available, the medical treatment as well. Though despite her age is 45, if she still wants to conserve her uterus, we can't deny that. So give the options of medical as well as the surgical. If she requires a definitive treatment and she need not, she is not willing to come for follow-up, or if she wants a surgery, she will opt it. I will give the options and she will decide, madam.
Okay, she will decide. And which surgery are you going to give her? Options. You're going to tell her myomectomy or you're going to tell her hysterectomy?
At this stage, she has completed her family, and I will go for a definite hysterectomy, ma'am.
Oh, again, you have to leave it to the patient. You have to
No,
counsel her.
if she has completed her family, myomectomy will not help at this point of age, madam. We are not.
No. There are some patients who might have, psychological setback. If you remove her uterus, she might think that she is good for nothing. There are some people who come back with that kind of feeling. So you need to discuss with the patient. If she wants a hysterectomy, yes, fine. If she's convinced about a hysterectomy, yes. Otherwise, if she still says, no, I have some patients like this. I only want the fibroid removed. I don't want the uterus to be removed. There are some patients like this. So ultimately, it has to be patient-centric, our management. So, but anyway, surgical management will be more tilted towards the surgical management than the medical management. But patient is 45. She says, I have read, doctor, I've gone through ChatGPT. It says that the fibroids will regress after menopause. I am nearing menopause. So, can you give me medical management?
I will give, madam.
Yes, ma'am.
You will give, right?
Yes.
So, what will you give?
Yes, ma'am.
Tell us.
Intrauterine contraceptive.
We should only give her what are all the choices. No longer do we take decisions for the patients. You have so many choices, advantage, disadvantage, please choose.
Yeah. What medical treatment are you going to offer? Now we have come to that.
Correct the anemia and then give the mefenamic tranexamic acid. We have to discuss the pros and cons. So every month, first correct the anemia and then tell her that every month she can take these medications.
First
and maintain her HB. She is willing for that because we have some patients, as you said, who want to just manage with that if they are around perimenopausal age group. But we can always follow them up after 6 months.
Okay, now, after 6 months, no, let us say after, okay. So her bleeding is controlled with tranexamic acid and mefenamic acid. She is happy and she is now worried whether my fibroid will grow or not. So in that case, you will call her after 6 months and you will call her for a scan, and you will also see what is the size of the fibroid and all that. Okay. Now, on the other hand, this patient is now worried. Somebody else has told her after 2 months, somebody has told her these fibroids can become big and become malignant. So what do you do in that case? She has come back to you now. What do you do?
You will demystify the myth and reassure her, madam. It will not become malignant.
Very, very rare occurrence, not in every case. We can always follow up.
So you will say, you will not say it will not become malignant. You will say it has very
chances
chance
are
of
very
becoming
less.
malignant.
It's just 1 in 1,000, so you need not worry.
Okay, now she says, I want some medical therapy which will also halt the growth of this fibroid. What do you do? I don't want the fibroid to grow. If you're only giving me tranexamic and mefenamic acid, it only controls my bleeding, but the fibroid is still growing. So what can you do for decreasing the size of this
So we
fibroid?
can, explain the choices between ulipristol and GnRH, madam, but we have to tell them clearly. Ulipristol, you have to do the liver function test every monthly and make sure, it doesn't affect the liver. So I honestly tell them, madam, the moment you tell them about liver, they all back off and they say, it's okay, let the fibroid be with me. So I don't think,
So there
once
are
you
other better
explain.
options, right? There are
Yes,
better options
GnRH
now.
you can give them. You can give them.
also be used,
You can go for elagolix now,
Yeah,
better option.
GnRH and
Elagolix, I think for adenomyosis, they are more prescribing. I'm not sure for fibroids whether they really
It is
have a.
also prescribed, but actually what I have noticed in my short span of using the elagolix is that the size doesn't decrease much in a short span of 3 months or 4 months, but the bleeding does get controlled. But even
Patients
the
are
bleeding,
comfortable.
it takes actually 1 month minimum. That is my observation. So the first month, it doesn't actually come down that much. The bleeding from the second month onward. What about the other drugs? Any other drug?
Ma'am, at GSI we have Lupride. So we
Mifepristone.
Even mifegest also you can give.
Yes, mifepristone also helps actually. In fact, mifepristone helps right from the first month onwards. What I've noticed is that there the bleeding comes down and the fibroid at least doesn't grow most of the time. But there are some cases where the fibroid has grown also, even after 3-4 cycles of mifepristone. Okay, so we have to explain all this to the patient, because what happened is one patient went to my friend, and she went and got all this medical management for 1.5 years. And after 1.5 years, the husband came and fought with the doctor. He said, if you had told me that this is going to go on like this, I would have got a surgery done, because I've spent more money on medicine than surgery. So that is again another thing we need to counsel them. It is a long-term treatment.
These drugs are cheap.
Yeah, what is that, Gayatri?
And that has to be told right in the beginning, ma'am, especially when
Exactly.
people's idea of avoiding a surgery is for the economic factor, because all these drugs are costly. None of them are cheap.
Exactly. And it is a long-term treatment. It is not a
And
short-term.
we also have the books telling us that once we stop the treatment,
it is going to come back.
If she's undergone menopause, it's not going to grow. But for the younger people who are on medical management, it tends to grow back again to the same size.
Ma'am,
Yes. Now then,
I beg to differ on this, madam. Only thing is, it's not only about the economics, because once we know, even if you retain the ovary, see, for 45 years, it is a dilemma. Most of us will even think of removing the ovary as point of time at 45. Or, okay, even if you think of retaining the ovary after a hysterectomy, the amount of functioning the ovary is going to do is going to be really compromised. So the, the impact on the heart and the bone health, we don't know. So I don't think, surgery is not the safer option. I think Mirena will be a better option so that bleeding comes down.
Okay, just a minute. Now, if it is a submucous fibroid, your Mirena may come out, or Mirena may not help much.
Yes,
Okay, in an
submucous
intramural
we
and
agree, madam.
subserous, yes. In a submucous fibroid, it's not really going to help, because it will come out immediately, or it will cause a lot of problem. Okay, so that is also there. So Mirena, in case it is an intramural fibroid or a subserous fibroid, then yes, it can really, if the cavity is fairly okay. Yeah, then yes. So Mirena also is an option. So we have so many medical options with us. So why should we go for hysterectomy, isn't it, in the first place? So basically, what we need to do is the right kind of counseling. I think with that, we'll move on to the next one.
It's getting late, ma'am.
Yes.
We have 10 more minutes.
The next case.
Ma'am.
Okay, we'll finish it fast in this one. 48-year-old para 3 living 3 sterilized, has complaints of amenorrhea for 6 months, followed by excessive bleeding PV for 1 month, associated with clots. So it is pretty simple, straightforward. Okay, no complaints of pain, no other past history or drug intake or anything important. On examination, she is comfortable. She's not dyspneic or anything. Pallor is only moderate. And on the PV examination, uterus is anteverted, normal size, fornices are free. Hemoglobin is 7 grams. Platelets are normal. BTCT normal. Ultrasound shows uterus normal size. Bilateral tubes and adnex are normal. Endometrial thickness is 12 millimeter. So can I have Dr. Vijay Lakshmi answering this?
Yes, ma'am. It could be possibility of endometrial hyperplasia, maybe the cause for the excessive bleeding.
Okay.
Correct. It is 12.
So you think it could be an endometrial hyperplasia because it is 12 millimeters and the history is so many months of amenorrhea followed by bleeding, isn't it? So how are you going to proceed with this? A perimenopausal lady, right? Perimenopausal lady, hormonal imbalance is there. Absolutely, uterus is normal. So it is a functional hormonal kind of problem, but you also want to rule out an endometrial hyperplasia. So what else will you do? List of investigations, please.
Routine investigation like the CBC, bleeding type corticum, thyroid, and ultrasound, madam. ultrasound, both abdominal examination and TVS we can do for the endometrial thickness and adnexal masses we can rule out, madam. Pap smear also as a routine for a perimenopausal age group, and we can still possibility of endometrial polyp, one of the diagnosis. So we can do for either 3D ultrasound or saline sonography.
So only if you are
MRI pelvis.
suspecting a polyp, yes. If it is looking like an irregular kind of endometrium, yes. Otherwise, you can straight away go for hysteroscopy. Why you go for a saline infusion here, isn't it? This is a case where you would probably like to go for hysteroscopy and biopsy, isn't it?
Yes.
You would like to see the endometrium. You would like to biopsy the endometrium. Any differences of opinion here? Other panelists?
I
Dr.
would like to do
Shanmugam?
a sugar, madam, because now everybody is diabetic, 48 years.
Definitely.
Okay. Yes. Yeah, agreed. Blood investigation. Okay. Now I'm talking about
No,
hysteroscopy. Anybody
is
has any difference of opinion here? Indicated. All are agreed? All my panelists?
Yes.
Dr. Shanmugam,
Yes,
everybody is
ma'am.
agreed?
Yes, ma'am.
Okay. So in these cases, like as Priya said, we have to do, of course, blood sugar also. We have just given the bare minimum investigations here. We will be obviously doing that. And after ultrasound, it will be straight away probably hysteroscopy and biopsy, right?
Ma'am, one more thing. Because we had a case actually in 45 years, she had a beta HCG positive actually, UPT. So we routinely do them. Sometimes it could be ectopic pregnancy also, or and then even at 51, you had
Agreed.
case.
Agreed. 100% we have to do a urine pregnancy test. Yes, that is missing here in this list. Very right. You have very rightly pointed out, because you cannot exclude pregnancy even if she's 51. Definitely. Even I've had pregnancies at 51 and all. Absolutely.
The moment we tell that,
must be done.
immediately retort saying that I'm sterilized, but we just have to tell them that there are rare cases of failures.
Yes.
Yeah, you need to do it.
Ectopic can be there. Yes, ma'am.
Ectopic also can be there. Even it could be a failure. So you have to get it done.
That's ectopic. All come under failure.
Yes,
what was that?
Ectopic or intrauterine, ma'am. A pregnancy is a failure of sterilization. So we have to tell them that.
Yeah, it can happen. So it can happen. You must tell them the incidents also. Rarely it happens like this. So you need to get it done. Okay. So urine pregnancy is very absolutely important investigation. So after this, you will be going for hysteroscopy. All right. So we are agreed upon this. How do you manage this? Hysteroscopy says it is a simple hyperplasia without any atypia. How are you going to manage this? Can I have Dr. Christie answering this? Dr. Christie, please.
Yes,
I saw her in between.
She's there.
So how would you like to manage this? So it is a
Okay,
simple
ma'am.
hyperplasia. What is that?
Sorry, ma'am. I was on duty, ma'am. Just went out and came.
Oh, okay, okay. We'll move on to the next person then. So, Dr. Shobna, what would you like to do in this case?
So, if it is an endometrial hyperplasia without an atypia, the risk of cancer progression is less than 5% over the 10-20 years. So, probably for this female, I would like to, for this patient, I would like to counseling regarding the Mirena, the LNZ IUS. So, if she is willing for that, I would like to offer her Mirena, madam. And
Okay, Mirena, any other choice? She doesn't want Mirena. She doesn't want Mirena.
Continuous
Continuous
oral progesterone has to be given, and she has to be also on follow-up. After 6 months, she has to take again an endometrial biopsy, and if the biopsy
So I would like to have attention from one person, please.
Christy, madam.
Sahiti, can you just mute,
Mute Dr. Christy?
madam? She's busy there on duty.
Christy, Dr. Christy, can you?
Yes, ma'am. She is muted. Yes, ma'am.
Okay. So, who was talking now? Let one person talk. Let's not have everybody talking in between. One person, please.
Yes, ma'am. Yes, ma'am. So, if this is an endometrial hyperplasia without an atypia, we know that the risk of cancer progression is less than 5% over the 20 years. So, I would like to offer her Mirena if she's ready for follow-up of, for every 6 months. I would like to take at least a 2 biopsy and make sure that everything is normal, ma'am.
Okay, so she's not willing for Mirena, I said. This lady doesn't want Mirena.
Give her oral progestogen for a continuous oral progestation, hydroxyprogesterone acetate can be given if she is willing for that, ma'am.
Yes, if
But
she's
I
willing for that.
need a follow-up. But I need a follow-up. I will definitely tell her that she has to come for the follow-up after 6 months to undergo a repeat endometrial biopsy. And
Correct.
if that
100%, I agree with you. She has to be willing for a regular follow-up. Only then you can give her all these things. Suppose the result comes out to be, next person, please. Suppose the result comes out to be cystic glandular hyperplasia without any atypia. Next person, please. Next person. Shobna has already answered. Who's next?
Okay.
Dr. Gayatri?
Yes, ma'am.
Yeah. So she has got cystic glandular hyperplasia. That's the report. There are no atypia.
Ma'am, this is a common finding, which is like in the perimenopausal bleeding. So by giving her, again, Marina can really help her. So we have to give her the option of Marina, where the bleeding can be effectively brought down so that her quality of life, anemia, all these parameters are better. But if she's not interested in Marina, then we can give her progesterone or progesterone, oral progesterone. But more than anything, even if we give her just a tranexamic acid during her periods, she's likely to settle down and take care of her anemia.
Okay, so if you give just tranexamic acid during periods, that will not be enough, because here there is cystic glandular hyperplasia. So you need to take care of that. It might progress. So it is not like simple hyperplasia. Now this is cystic glandular hyperplasia. So you need to give her progesterones. Okay. So you need to give her progesterones either intrauterine or, I mean, you are giving as an oral tablet. Yes. Okay. So then I think what else is there? Okay, it comes out like a few atypia here and there.
So if it is a
Then we go for
hysteroscopy and you do a atypia here and there, then I think we should like counsel the patient. You just have to tell the patient the chance of progression to malignancy is around 25 to 30%. So it is her decision, her call. And if she, because I mean, if
But
it's a
here
fertility
you have to
patient,
counsel her. Probably you'll have
or
to counsel her
surgery.
more towards the surgery hysterectomy, because she's already
And
48 years.
45 years completed family, so that is a choice. There are like nowadays we come across with patients who are like, in their fertility treatment at 42, 45 years, where they can like, even opt for donor and they come back with we want the uterus. So in those cases, again, we give them either a Mirena or a progesterone. High dose
But when you
progesterone,
have
we will be
atypia, in atypia, one minute, Priya, when you have atypia, when the specimen comes as histopathology comes as atypical atypia, there is more chances of simultaneous endometrial adenocarcinoma. So
yes,
always,
in situ can be there. We have to tell the patient, madam, because nowadays we get these patients like, routine practice, 42, 43 years, where they come with atypia and they don't want to give up on the uterus already. Because now surrogacy is becoming a tough job nowadays. It's not easy to get a surrogate for them also. So like they want to retain.
Priya, understood your concern, but then she has to live, no, for her to bear a child. You need
So
to tell her
we
that
will
also.
call her back in 3 months' time, madam. We'll give her the progesterone therapy, call her back in 3 months' time for a biopsy. So you mean like, if she wants to retain, if she's willing for hysterectomy, then yes, definitely hysterectomy will be the first option for her.
And you will call her earlier if she continues to have some bleeding. Because sometimes even on progesterone, she might be having some bleeding which is happening in between. So in such cases, you must tell her. So you must tell her the risk here definitely. Okay, because atypia, because your pathologist might, they are not doing the whole endometrium, right? They are only taking a few bits and then they are telling. So there might be malignancy hiding somewhere else. So we have to take that seriously. Okay. So, okay, what is the next slide then? I think we'll move on to the next case.
Move to the next case.
Yes.
Priya?
End of
okay, I'll just read it out. So the treatment options here, antifibrinolytics, NSAIDs, iron supplements, birth control pills. Now, birth control pills, we will not be giving it in this 48 and 45-year-old. And HRT balances. How about this? Estrogen and progesterone, there are some preparations. No, little bit of estrogen and progesterone to be given for menopausal, perimenopausal ladies. Anybody is using? In cases where there is no atypia.
For patients, not for heavy menstrual bleed, madam, but for HRT we have used. I mean, there is a combination where they have it with dydrogesterone also. And dydrogesterone actually is a very good progesterone when you give it in the combination like this. So can be tried, but never tried for these indications. Sorry.
I have tried and I have found that unfortunately it actually leads to irregular bleeding. In fact, the combination that was available was giving rise to irregular bleeding. So I stopped using it anyway. So there are GnRH analogs, antagonists temporarily stop bleeding. Ormeloxifene, yes, we have not mentioned that at all here. Anybody is using?
Actually, I have been using it previously, madam. The only thing is it controls bleeding perfectly, beautifully it controls. The only problem is that it comes and causes like, a thickened looking endometrium. And maybe after when they come for follow-up for a scan, when the endometrium looks thickened, they get literally worried. I mean, the biopsy comes as normal. It is not hyperplasia or malignancy, but the patients start getting a little worried. So that is
And
the only
not only the
drawback.
patients, even we start getting worried because the looks of the endometrium are very scary actually. Okay,
Yeah,
so if you're
true.
giving it for a long time, that is a problem. Okay, then what is the next one? Mirena IUCD, that I think all of us are agreed we will use it. Go on to the next case. Case 4. Do we have time?
Yes, ma'am. One more please.
Can we
Yes,
finish
quickly
it?
go ahead. Whatever,
Yes, ma'am.
quickly go ahead.
ஹலோ
Yeah,
மேம் மேம் நீங்க பேசுறீங்களா மேம்? நான் டெலிவரிக்கு போறேன் மேம் கேஸ் ஃபுல்லா.
Thank you, madam. Thank
நீங்க
you for being with us.
ஓகே ஓகே தேங்க் யூ.
Thank you,
Okay,
madam.
thank you. Thank you very much.
Doctor,
Okay. I think I'll just quickly finish. We'll finish it in 5 minutes.
Okay, ma'am.
Exactly 5 minutes.
Yes, ma'am.
Okay, now case 4, 28-year-old. So this is a young lady, had LSAS 18 months back. She's still breastfeeding and she complains of excessive bleeding PV on and off for the past 1 month. Her previous cycles, actually, she resumed menstruation around at the time of 1 year. And then for the last 6 months, she was having a regular bleeding. Only for the last 1 month, she's been having irregular bleeding, okay? She's got a mild pallor, she's afebrile, vitals are stable, and uterus is, per abdomen, uterus not palpable, per vaginal, os is closed, uterus bulky, pons is free. Now, this is a lactational lady, uterus bulky, HB is 9.5 gram, platelets 1.5 lakhs, urine pregnancy test negative, thyroid function test normal, ultrasound, uterus normal, endometrial thickness 7 millimeter, ovaries are normal. So basically what I'm trying to say is there is a little bit of anemia, but all investigations are normal. Endometrium is normal in thickness. It's a bulky uterus, lactational. Please tell me, what do you think of it? What will you do? Somebody can take it up. Dr. Radhika?
Yes, ma'am. Again, the usual investigations like, our UPT, complete blood count and all those things we do. And we correct the anemia first, and the thyroid function test is important. And it could be anovulatory also. So we need to correct the bleeding as usual, like with the tranexamic acid. And then start her, but the progesterones may thin her, but we can thin her endometrium further. But we still can try that out for some time and then stop the bleeding and then start her on combined oral pills.
So endometrial thickness was normal here, isn't it?
Normal,
okay.
yes,
So basically your diagnosis is it's a hormonal imbalance, it's a lactational, okay. So it's a functional problem. So you would like to correct
common
it.
is that, madam, but always we try to do the beta HCG level for these patients who have delivered, always to keep in mind of the persistent trophoblastic disease or the neoplasia, which is quite common after the delivery patient.
Yes. So ultrasound also done and urine pregnancy test also done negative. Serum beta HCG is also negative. It is low.
Yes, ma'am.
So this is not very rightly said, pointed out by Dr. Priya. We need to also think about pregnancy or choriocarcinoma. Yes, both the things we need to think and keep it in mind. Okay, right. So hormonal imbalance first. Next thing is this. So once we've ruled out these two things, okay, then what would you like to do? Estrogen plus progesterone. Okay. Do you need estrogen progesterone always? Sometimes just NSAIDs and tranexamic acid will work.
Yes, ma'am.
Will work.
And
So what about this
LNG?
energy insertion?
Yes, ma'am. It is very useful usually in this reproductive age group. It can also act as a contraception as well as
so if he is already 18 months, so you need to discuss with her whether she requires contraception further or she wants to conceive again. That is another thing you need to think about. The second thing is that LNG insertion, if you insert, I don't know what you have found, but in my experience, in the first 3 or 4 months, it will not relieve the problem. It will be having more of irregular bleeding. Only
we should
after
counsel them, ma'am. For 8 months, they will bleed.
It will take at least 6 months in most cases to settle.
Yes, ma'am.
So the patient has come to you with 1 month of irregular bleeding. So I don't know whether you have to really discuss with her, and you need to start her on oral tablets as well, along with inserting the IUCD, so that after some time it will take charge. Okay. Now, what about combined oral pills in these patients? Fine, isn't it? Absolutely fine.
Yes, ma'am.
Thank you, ma'am.
So what about ormeloxifene?
That is a very good option as well.
Can be given.
Can be given. In this patient, definitely will be good. Only problem is every now and then she'll come and tell you, am I pregnant? So she'll be going on doing urine pregnancy test every now and then. That's the only problem in this. Otherwise, it's absolutely fine. Okay, so in Okay, so I think we have discussed most of the scenarios, and since we are getting late, I would like to thank you all, my esteemed panelists. All of you are wonderful. So giving,
Thank you, ma'am.
you were so spontaneous and giving all your ideas, and we all know that all of you have a busy practice. That's why you're all you're just coming out with that. So thank you very much, and thank you very much for the organizers and the coordinators, beautiful coordinators. Thank you very much.
Thank you, ma'am. Thank you, ma'am.
Thank you, madam. Thank you,
Thank you,
TNFOG,
Vidya,
for
ma'am.
giving us the opportunity. Thank you, ma'am.
Thank you, ma'am.
Thank you so much.
Vidya,
So
ma'am.
we'll wrap it up.
Thanks. Yes,
Yes.
ma'am.
A
Yes,
formal vote of thanks. I'd like to thank our chief guest and guest of honors for taking time to be with us and bless our program today. All the judges who've been they are actually running the marathon, who've been the judges for the episode after episode to judge our Yuvas. The Yuva speakers who did a wonderful job today, our speaker and our chairperson for the talk, Manyata, Dr. Revati Janakiraman and Dr. Chitra, and our esteemed and beautiful, heavy menstrual bleeding. Almost all the points touched our moderators and all my co-panelists. Thank you all for being with us. And delegates, without you logging in, nothing is going to be a success. So thank you all for joining in great numbers. And I would also like to thank Mrs. Shripriya, the event manager, who's able to get all these things done for us very smoothly. Because of her, though, in spite of all our practice, we are able to do this. And I thank the president and secretary for making this happen and going on, and also the Shield for their platform. With all this, let's also thank the God, and before we close this program, thank you all.
Thank you very much. Thank you.
Thank you, ma'am.
Bye-bye.
Bye, ma'am.
We'll meet
Thank
you in
you,
the
ma'am.
next CME. Okay.
See you,
Bye-bye.
ma'am. Thank you, ma'am.
See you.